Thank you. So good afternoon and welcome to the House Health and Government Operations Committee. I am your chair, Jocelyn Peña-Melnick. I have with me to my left the amazing Speaker of the House, and we're honored to have her today in the committee. I kindly ask for your patience today if we encounter any technical or streaming issues. Sometimes it happens. This briefing is being streamed on the Maryland General Assembly YouTube channel. Before this briefing, all members were emailed a copy of each presentation. If you do not have these documents, please let the staff know and we will send you a copy. I want to thank the staff for sending us the information ahead of time and for all the work they do to put these briefings together for us. For the committee, please adhere to our usual committee rules of one question and one answer from the panel, not one question, one answer from each panelist. And please keep your questions brief. Today, the House Health and Government Operations Committee will hear a presentation on the AHEAD model and the Emergency Department wait time from the Department of Health, the Health Service Cost Review Commission, HSCRC, and the Maryland Hospital Association that is being led by our wonderful colleague, former Senator Melanie Griffith. The department and the HSCRC will present on both issues and will be followed by a panel from the Maryland Hospital Association as well, and they'll present on both issues. The committee will then hear presentations on community violence prevention, and we're going to begin today with Secretary Herrera Scott from the Department of Health. Is she here yet? Yes, come. If you can come up and bring your panel, please. That would be wonderful. Yeah. Yeah, I see it right here. Thank you. So Secretary Scott is going to present on the AHEAD model, and with her, she'll have John Crone, the Executive Director of the HSCRC, and Craig Bem, the President and CEO of CRISP, and they're available for questions. So good afternoon, Madam Secretary. How are you?
Good. How are you? Good afternoon, Madam Speaker, Chair Peña-Melnick, and Vice Chair Cullison. My order is off with you, Madam Speaker, so apologies in advance. But thank you for having us, and we're here today to give an overview on AHEAD. Oops. So, the goal of the total cost of care model is to ensure a world-class system of health for all Marylanders, and certainly focused on equity and excellence in care delivery and improving the health. When we first started, almost a year and a half ago, thinking about the next version of AHEAD, one of the things that we wanted to ground in is what's the vision for the model? Why do we have this model? And this was an attempt to come up with that vision, especially also thinking about the continuum of care. So health that's delivered in the community, primary care, specialty care, hospital care, post-acute care, palliative care, and end-of-life care. And certainly under the new governance structure for AHEAD, it touches on almost everything that's on this slide. Of course, we want to focus on equity, community, and population health. The one thing that's missing from this slide, though, is data. How do we use data to inform this process? So this is a little background and where we are today. So again, this is the all-payer hospital rate-setting system has been in place in the 70s. And then in 2014, we renegotiated that all-payer rate setting into put hospitals having a majority of their budget under global budget. And then in 2019, that became the total cost of care model. And now AHEAD is the future for the total cost of care model that's thinking about all payers, not just in the hospital, but outside the hospital, specifically focus on primary care. The strengths of the model, it enables cost containment for the public. It ensures all payer hospital charges correlate with costs. It guarantees equitable funding for uncompensated care, creates transparency and cost savings for the public, and it stabilizes financing system for hospitals, funds investments in population health, establishes Maryland as a leader in linking quality and payment, provides support for pioneering state health care, infrastructure and subject matter expertise, incentivizes care transformation across all care settings, invests in primary care, and allows for innovation. One of the things, two things that I do want to highlight is because of the way our hospitals are funded, we don't have any safety net hospitals in the state of Maryland. And we also have not been impacted the way other states have with hospital closures and service line closures. I think many of you have read about, especially in western parts of different states, if the hospital doesn't close, then they close core service lines such as maternity care. And that hasn't happened because of the model. So where are we going? So again, it continues to build off of the total cost of care model, which is currently authorized through the end of this year, or is it through December 2026? And then CMMI has said the future of the model is under the all-payer health equity advancing development model as their attempt to try and move other states to the work that Maryland has done. And it's really thinking about population-based payments. So it builds on the total cost of care model. It's curb growth in healthcare cost spending, improve population health, and that's with the primary care investment targets. So that's been happening under Maryland Primary Care Program, but then the MHCC has also been working on increasing investments for primary care, and then advancing health equity by reducing disparities in health outcomes. We know healthcare disparities cost the healthcare system millions and millions of dollars, and so how do we start addressing some of those disparities, not only to improve health for all Marylanders, but also to impact the total savings under the total cost of care model. And clearly at the center of all this, hospitals are a primary driver with wraparound services as primary care as we think about going upstream and stabilizing people in the community, and then going upstream even further by some of the population health activities that happen at the local level, such as housing supports, which I think you're all familiar that Maryland Medicaid just got an 1115 waiver to provide those wraparound services. But if we can stabilize people in their homes, we can stabilize them in their community, reduce total cost of care, and that's what that outer green bucket is. This was what we submitted as part of our notice for funding opportunity as part of AHEAD. We want to ensure high value care. We want to improve access to care. One of the things the total cost of care model has done has created access points for everyone, regardless of payer, but that doesn't hold true when you go outside the hospital walls. So how do we make access to primary care and other services more equitable, and then certainly promote health equity? Across all of these, there'll be a level of accountability, not only from the state, but certainly from CMMI as we roll this out. The infrastructure you'll see there is data and analytics, workforce, which you'll hear about from the Hospital Association, not only in how much it costs, but how much we need, health information technology, and that's where Chris comes in. And then across all of this, what we've heard from the docs is you got to simplify it. You've made it too complicated with all the different quality measures, all the different payers. So how do we think about administrative simplification? And then last and foremost, we do have to have a statewide health equity plan that drives all of this work. So we are, again, creating equitable, improved health care for all. That, I'll turn it over to John.
Great, thank you. So just to kind of put it in stark terms, the participation in the AHEAD model and yes, is that better? Great. Yes, White House appreciates it. So to put it in stark terms here, right? Participation in the CMMI model is a necessary requirement, right, for us to be able to preserve some flexibilities and benefits that we've enjoyed here in Maryland for many, many decades. So we've put some on the slide here. There's $1.7 billion in federal payments for Medicare and Medicaid patients, and as such, hospital rates for public payers are higher than rates at peer hospitals nationally. That's incredibly important for one, keeping rural hospitals open, keeping hospitals open that see a high proportion of public payer patients. And two, from the perspective of Marylanders, right, having access to acute care services, if you're a Medicare beneficiary or a Medicaid beneficiary, this benefit is incredibly important to that. The other thing I would mention here is the uncompensated care function that we've enjoyed for many, many years here in the state. That's also enabled by participation in the model as well. And as the Secretary mentioned, that is how we are able to maintain our system that doesn't require safety net hospitals in the state. So it's important to note, though, however, the AHEAD model doesn't inherently solve all healthcare finance challenges, right? So the AHEAD model doesn't govern all aspects of the healthcare delivery system. There are many challenges that we're facing, and we're going to have to work together as a state to manage in parallel to AHEAD implementation. So, for example, nationally, the cost of physician coverage for hospitals is rising much faster than other hospital costs, right? So the AHEAD model doesn't provide new tools for states to manage this, but it's a critical challenge facing hospitals in Maryland. The AHEAD model gives us some flexibility to think of some innovative ways to address this in Maryland. While physician costs aren't a regulated hospital costs included in hospital global budgets, I will say we, the HSCRC, are working very closely with hospital partners to collect data on this really critical cost driver, really now as we speak, so that we can work together as a state on developing some solutions for this, for the long-term stability of our healthcare delivery system. The AHEAD model does establish a statewide health equity strategy, as the Secretary mentioned. It helps fund investments in population health. It continues improvements in healthcare affordability. It supports our healthcare delivery data infrastructure as well, including CRISP, which is really a crown jewel of our data infrastructure here in the state. And it incentivizes care transformation, not only in the hospitals, but beyond through the primary care objectives and programs enabled by the hospital. This is all memorialized under a broad framework in a state agreement that we have signed with the federal government back in November. So that memorializes CMMI's commitment to the all-payer hospital rates and preserves the state's authority to set policy to manage hospital global budgets, population health, the Maryland Primary Care Program, and the health equity strategy. So again, I'd point out here that the AHEAD model doesn't, and the state agreement doesn't enumerate solutions to all challenges. It gives us the opportunity to drive innovative solutions. So in particular, the state agreement doesn't lay out our specific hospital global budget policies. These will continue to be set at the HSCRC level. And we have started what will be an extensive stakeholder-involved process to review our core hospital global budget policies to strengthen our model in advance of AHEAD. In particular, what we're working on is policy refinements to ensure that global budgets support access to acute care services, commensurate to the evolving needs of our regional populations. And we want to ensure that our volume policies adequately adjust hospital revenue as patients move from hospital to hospital. So these are the types of policy levers that aren't specifically enumerated in the state agreement, but it gives us flexibility and contemplates a state being able to manage that over time at the state level. I would also say that we've done a lot of work over the last year to identify and work with hospitals to identify opportunities to strengthen our model right now. So to give you an indication of the urgency with which we're working to that end, over the past 9 months, we have increased rates over and above current inflation and grown hospital rates by over $1 billion in our annual rate adjustments this past year. We created a temporary hardship fund of over $80 million for hospitals with particularly challenging financial positions. We made an unprecedented permanent mid-year adjustment to rates to help with staffing costs. We modified our capital funding policy in a way that enabled the new hospital project in Easton to move forward. And we created a high-cost drug policy to ensure that hospitals who are providing cutting-edge but very high-cost drug therapies to treat things like sickle cell and cancer and other diseases are adequately reimbursed for those costs. So throughout this process, we've worked very closely with our hospital partners, and special thanks to our colleagues at MHA. We meet very frequently to get their feedback on the technical policy work, but that cadence will really need to continue as we move forward in what's going to ultimately be a very busy year. This timeline shows some of the milestones that we're going to have to hit over the next year, and then we'll also, in parallel to this, have to do that policy work at the HSCRC at the same time. So with that, I will turn it back to the Secretary for an update on the Maryland Commission on Health Equity.
Thank you, John. So one of the requirements when we applied for the grant is that we had to have a governance structure over this work, and CMMI was prescriptive on what they wanted to see that governance structure look like and who should have a seat at the table. And as we looked at our boards and commissions, we were trying to not have another new entity. The Maryland Commission on Health Equity match the requirements from CMMI. And so we made some changes, as many of you recall, last year when we introduced this legislation. With your support, we got it passed. And so the Maryland Commission on Health Equity is now the governing structure for parts of the AHEAD model. So this was the membership composition. In the prior version, it was mostly state cabinet members. And we wanted to include, you'll see in the middle, the continuing members, but we really added many more people from the healthcare industry, including our partners at the Maryland Hospital Association and actual hospital representatives, but the Community Health Resource Commission, federally qualified health centers as we thought about our expansion of primary care, MCO and commercial insurance representative, clinicians providing the care, as well as tribal community representatives and patient representatives, just so they had a voice at the table. And then what we're charged with doing is coming up with the state health equity plan, and then tapping into all our partners at the local level, our providers, especially the hospitals, but the local health departments, the local behavioral health authority, our payers, to inform the care that we provide at the community level, and then build these population health action plans for the community to help drive some of those population health improvements. CMS has provided a template to use with 5 key parts that they want to address. So identifies health disparities and population health focus areas, sets measurable goals to reduce disparities and improve population health, identifies evidence-based strategies to advance towards those goals, informs plans for allocating resources, and develops processes to include the stakeholders in implementation. And so we had started some of this work already at the health department through our state health improvement process, and some of that state health improvement process and the measures under that process is informing that work. But in addition, CMS is defining the work. They've listed 5 core domains where they want the components to focus on: population health, prevention and wellness, chronic conditions,
behavioral health, which is new for this model. Behavioral health is very much included in whole person health as we think about driving improvements at healthcare quality and utilization. And then they provided an optional domain. And of the optional domain, we could pick one of the three that you see there: maternal health outcomes, prevention measures, and social drivers of health. And through our first MCHI stakeholder process, we've landed on maternal health outcomes as our sixth domain, given all the work that the state has done in protecting women's rights, and especially the work we have been doing on addressing infant and maternal mortality and morbidity among Black women. The state health need must identify the domain. They need to align with AHEAD and certainly population health targets in each domain, and then subpopulations potentially, such as under the maternal health domain, looking specifically at Black women, which are largely impacted with deaths post-delivery. In addition, we need data to inform all this work, since to set what the milestone should be, what should be the improvement. So this is not a requirement, but we have formed a data advisory committee to inform the work and provide the data necessary for MCHI to make decisions on. And this is just the list of people who raised their hands to participate in the data advisory committee. We had more people, we had 92, more than 90 people apply or want to be part of the data advisory committee, but we really didn't want to make it too big. I think there's about 25 or 30 people, but these are the areas of the state that they represent. And we asked from all of these areas that they have some experience in working with data and analytics and setting targets, and some expertise in the clinical domains that were defined from us by CMMI. And that's the end of this part of the presentation. So I will stop and we welcome any questions you may have.
And thank you, Madam Secretary. Thank you for all the work that you and the HSCRC and the hospitals have been doing. We really appreciate it, especially because you're going to be investing in population health, right? Which is what we want to do. As well. I'm going to open it up for questions, and I'm going to start with Delegate Hutchinson, followed by Delegate White-Holland.
Thank you, Madam Chair. So it's a new model that's, this is about the HEAD model. So it's a new model that's coming out. How comfortable are you that the model will work, will keep hospitals out of financial instability, particularly those that are having increased patient volumes?
Sure. Yeah, I mean, there's certainly work to be done, right? I think what I would answer in two ways, right? One is that benefit that we receive through our waivers to Medicare fee-for-service payment are like, that is critical, right? For the absence of that would be really a huge burden for the healthcare delivery system. You know, I think we have flexibility. I think we have adequate flexibility to look at our policies to ensure that those volume adjustments can be made. We have work to do, right, to refine our policies in order to make sure that that's working properly. So that work is continuing. You know, as I mentioned, though, there are these cost drivers that are kind of beyond the regulatory infrastructure of the state. For example, physician cost for staffing a hospital that we're going to have to work on, right, collaboratively here over the next.
So if it did cause instability, though, within a particular hospital, what resources or what would the HSCRC be able to do to help, or what would happen then?
I'm sorry,
if it did create instability for a hospital, you know, reduce margins. What resources or what would HSCRC be able to do?
Yeah, well, so our rate setting authorities are the mechanism by which we, you know, can you know, adequately adjust reimbursement based on, you know, whatever regulated cost driver. Now, that's not, you know, that's limited to the costs that we can regulate. So this is like typically these are like the facility costs within a hospital. Sitting outside of that, the physician costs are the major aspect that sits outside of that. But yes, we have tools in place to kind of weather some storms, right? If, for example, as COVID hit, right, we were able to smooth out revenue over that time period. This is the kind of tool that that the AHEAD model provides us with.
Great, thank you.
Delegate White-Holland, followed by Delegate Taveras, then Delegate Hill.
Okay, thank you, Madam Chair, and thank you all for being here and sharing these updates. This also made me remember the recent briefing we had from Director Blakefell related to the Office of Minority Health and Health Disparities, given the health equity update that was provided. And so I see a Venn diagram in my head, just as you presented, related to the commission being a model and recognizing that CMMI accepted that governance structure. And so could you expound upon how that work also overlaps, or how one hand washes the other, or where is the overlap, or how is this work coupled with the work that we're already doing within that office and within the commission that is helping to inform either of those particular processes with the head, but also with our own internal work as a department and as a state?
And if I could just go back to the Maryland Commission on Health Equity, there is still many deliverables that's in that law that we are still responsible for.
Yes.
I just didn't call those out in the AHEAD deck. So, and where there's overlap, and that's actually a great idea, and we can put something like that together to show where the overlap is between the core requirements of the Maryland Commission on Health Equity, the AHEAD model, and then the Office of Minority Health and Health Disparities. But for instance, looking at chronic conditions, that's one of the domains under AHEAD. Breaking out that data by race and ethnicity, or looking at health disparities. It defines other groups that it wants us to break out that data on, but the soundness of the data gets less and less and less as you start to add groups. So, but we know for age, for race and ethnicity, we have pretty good data. Medicaid data, we have about a 90+% match through the work we're doing with Hilltop. I've shown some of you in the room the prototype of what that looks like, and we're still working on a visual display, but we can now break out those chronic conditions. You can see them geographically, where the variation is, and you can also see them by race and ethnicity and age, depending on the condition. So we're starting the other requirements as well, and unfortunately I did not bring that here, but we can certainly come back to the committee with that Venn diagram showing where it all comes together under the original requirements of the Maryland Commission on Health Equity, including the Minority Health and Health Disparities, the Office of Minority Health and Health Disparities.
Yes, no, I think that would be great because, again, I can see how we've already led in some of these spaces with some of this work. And in order to avoid duplicating efforts, there's work that can be assistance in both of these areas. Thank you, Madam Chair.
You're welcome. I have next Delegate Taveras, followed by Hill.
Thank you, Madam Chair. So as you clearly highlight, this is a population-based model. And I want to thank you for the presentation. It's very thorough. One of the things that I was able to discuss with some of the stakeholders is that so one of the issues that you highlight, right, that there is a need to have more thorough discussions regarding population and staffing and such. But another of the issues that I think may be also is in need of further conversation is what you are putting in under the provide support for pioneering state healthcare infrastructure. Can you expound a little bit on what you mean by that? Because when I think about that, I also think about the sustainability of healthcare, not just keeping the status quo, but how do we account for depreciation of equipment? How do we create cost savings so that we can provide over the life of the depreciated item the ability for new items to be invested in and supported. So are you accounting for that data for creating coefficients of depreciations of equipment as things are eliminated in hospitals and in the infrastructure of the hospital building?
So I can't speak to the depreciation, I'll let John take that, but I just want to give you an example of what we have used monies for. So we know in certain parts of the state, primary care is really, really hard for certain people to access. The panels are full, there's not enough providers. So we recently put out $20 million worth to create new access points around the state where we knew primary care access was a problem. So as I said, access to care for hospital care is equitable regardless of the payer status, but that's not the case outside the hospital. And so we use, federal criteria such as health professional shortage areas and other data points to define where we needed primary care. For instance, we now will have primary care access in Edmondson Village in Baltimore City, which was, despite it being in the city, a primary care desert, for lack of a better description. We have 2 new access points in Prince George's County. I don't have all the sites, but we have expanded access on the Eastern Shore, Western Maryland, Prince George's County, Baltimore City, and other parts of the state by funding 11 new sites. And what that means is we've provided infrastructure for the sites to build out the primary care site, for equipment for the primary care site, and even covered expenses related to hiring physicians in the first and second year. And the idea is that they would roll into the model in year 3, but startup money to create new primary care access points. You want to take the depreciation?
I'm happy to talk a little bit more about depreciation. I think one of the things, so we do track at the HSCRC both cost report data, which would include depreciation for regulated regulated entities, as well as balance sheet, right, which would be more cash flow, independent of or related to depreciation. I think as we move forward and think about kind of refinements to policy, right, as we get more complicated, right, in terms of the needs of different regions around the state, you can imagine that depreciation means something different to a hospital that is in the process of moving services out of that high-cost hospital setting to a lower-cost setting, like the primary care setting that the Secretary mentioned, versus a hospital that might, for example, be in a part of the state that is growing volume, right? The depreciation means a very different thing, and so we have to think about it differently. So as we go forward, a lot of our policy work is gonna have to be like, look, we can't look at everything uniformly across the state. We have to understand and contemplate the regional differences across the state. So that's a lot of the work that we're undertaking now.
Thank you.
So we have next Delegate Hill, followed by Bandari, then Shalega, then Vice Chair, and then Bagnall.
All right. Thank you, Madam Chair. Thank you, Madam Secretary. John, thank you for the work and for being here. I have a couple of things I wanted to clarify, that I heard them correctly, Madam Secretary. I think you said that we don't have the problem of hospitals shutting down lines of service that we see in other places. I'm not sure I heard the context correctly.
So in other states, especially during COVID, we saw nationally many hospital closures. And if we didn't see hospital closures, we saw rural hospitals just closing their OB departments and women having to travel long distances to get that care. That's just one example. There were other service lines that were closed because of the financial state during COVID. But in Maryland, because of the way John described, we pay hospitals, that didn't happen during COVID.
Okay, so it's COVID specific, because certainly we've seen, and we know here, for instance, Laurel, Greater Laurel, closed some years ago, first took its OB down and then closed, and then we had University of Maryland come in. We've seen it up in Hartford County. We've seen it on the Eastern Shore where hospitals are closing, they are struggling, and I just wanted to make sure you're talking
Yes.
COVID specific.
Well, it is COVID specific, but it still endures compared to other states and the number of hospitals we have in the state.
Okay, because I think that's still a problem for us. And the other point of clarification is HSCRC just controls hospital rates. It doesn't control physician rates. And generally speaking, if I have it correctly, you said that hospital reimbursement rates are higher than national comparisons, right? But we also know, I want to make sure I'm clear, that physician reimbursement rates are lower than national. So we've got some kind of imbalance, which many of us are hearing is contributing to physicians not wanting to stay in the state, not wanting to participate, behavioral health providers only wanting to be fee for service, cash only, and a lot of primary care is going into concierge practices. So I'm correct about that, right? Okay. So how does the HEAD model, which is frankly a national expansion of what we've been doing here and what we've been bragging about, and we've got these problems, what happens in the HEAD model when we've still got these issues to deal with?
So if I just talk about what we're doing in primary care as an example, we are actually making investment targets for primary care as the example. And under MD PCP, not only did the providers, which was focused on Medicare beneficiaries, get an enhanced rate, but they also got a per member per month or a care management fee, and they also got to participate in a quality incentive pool, for example. So additional dollars for hitting certain targets. And now under AHEAD, MD-PCP continues. We've expanded primary care, and once those practices that I just described are up and running, they will go into one of the models, MD-PCP, if they're ready for more advanced payment model. But we also have a model that they can enter, which provides a per member per month, still the enhanced payment, and then now Medicaid as well. So with all of your support, we now have enhanced rates for primary care on E&M codes, and they will also get a per member per month care management fee. And then we're working on what a quality incentive target. So we are moving from a state, normally in most states, primary care investment is about 4.5 to 5.5 cents on the dollar, and we are approaching 8 cents, 9 cents on the dollar. So we are making more of an investment in primary care than we ever have before, and I would say even compared to other states. Now, is there still room for improvement? Absolutely, especially as we think about other provider types like behavioral health, because we need to do a better job. We are keeping people out because the reimbursement's not high enough, and then many actually ask for payment up front, which many people can't afford, but that's certainly on our radar of something to address.
And how long do you anticipate before we will begin to feel or know if we've stopped the bleeding or stemmed it, if these measures are actually helping?
Hopefully by more people choosing to stay in Maryland to provide primary care. I will also say now with a new medical school coming online and people having the option to be dedicated here, to be educated here and stay here, that's certainly an opportunity. I will share, I'm a native New Yorker, came to Maryland for my residency. Really, Baltimore became my home and I stayed. And for many years, I provided care at Penn and North at the Men's Health Center and the clinic that was upstairs and on Caroline Street. So, that's how we attract people to the state, give them an opportunity to get educated here, fall in love with the state, and then stay.
Okay. May I have one more?
You can have one very short one.
Okay. Yeah, so this is pretty simple, and you've heard this from the hospitals as well. We have decreasing numbers of beds, which I'm sure will come into the discussion of the ER wait times. What is the evidence that we have that we don't need all these beds that we've been closing? And hospitals seem to be able to keep the money if they close services and send it elsewhere. So there seems like a perverse incentive to provide less care.
Yeah. So I would say there's kind of couple indicators here. One is when we look at the number of beds that have been reduced relative to kind of volume reductions, just generally for Medicare nationally, right? It is greater here in Maryland over the past 10 years. But also, we can compare that to how far above national average we were in terms of utilization, right? So that, I think those lines kind of meet in the middle. But to my earlier point about regional differences, though, I think what we're starting to see now is that in some parts of the state, we are still high in terms of like total utilization of inpatient services and outpatient services. But in some parts of the state, we're getting to lower levels of utilization. So that would suggest to me that, right, we can't look at the total number of beds across the state. We've got to look regionally, and we may have some areas of the state where we've got to grow.
Maybe you could share with us the outcomes. It's really health outcomes we should be measuring, not utilization. And I think that's maybe part of the problem. We look at utilization, which doesn't tell us anything about whether people are actually healthier and doing better. And we're hearing that they're not. Okay.
This, if I may, as a follow-up to Delegate Hill, this model is a 9-year model, isn't it? Once it goes into, because you're now into the phase of it that started in July and it goes until December 2025, right? Then the primary care starts in 2026, correct? And you will continue the enhanced payments for the doctors, right? And then this, under the board, you will have 3 committees pretty much to do the work, right? And I'll tell you what I'm getting. You have the Population Health Committee, right? And Transformation, the Healthcare Committee, and Primary Care. So you have the flexibility to be able to adjust and look at not just the data, right? But what Delegate Hill is also suggesting, and anything else that can come up. Am I right?
Yes.
All right. And can you tell me, as part of the composition, I saw that there were 2 hospitals, one urban, one suburban. Do we know who those hospitals are?
I don't have the list for the Data Advisory Committee, but I can certainly follow up with who the hospital representatives are on that committee. There are 2 hospital representatives on the MCHE, on the Maryland Commission on Health Equity, as well as a seat for the president of the Maryland Hospital, or for the Maryland Hospital Association. So the 2 hospital seats on the Maryland Commission on Health Equity is University of Maryland and Meritus, in addition to the Maryland Hospital Association.
And the 3 committees that, will be created, will the hospitals be on those 3 committees?
Yes.
Okay. And on each of them, will there be representation, for example, on the Population Health one, the Healthcare Transformation Committee, and the Primary Care one as well?
So there were 3 committees that advised on the application that we submitted to CMMI, which was a hospital committee, the primary care committee, and the community population health committee. And it was open to hospitals. I know there were hospital representatives on the primary care committee because many hospitals own primary care practices. Clearly, there were hospital representatives on the hospital committee. I can't remember the list for who was on the Community Population Health Transformation Advisory Committee off the top of my head, but I could certainly get you the list.
That would be great. Thank you. I have Delegate Bandari, followed by Delegate Shalega.
Thank you. Thank you, Madam Chair, and we are blessed to have our speaker with us. And thank you, Secretary, for highlighting why Center for Medicare and Medicaid Services, CMS, selected our state as cohort 1. So as you heard, our committee highlighted some structural vulnerabilities. It's a wonderful program. The mission is to curb cost, improve health, and advance equity. In the meantime, there are structural vulnerability like financial sustainability, provider participation, and workforce shortage, and the care coordination as well. So this committee is interested to hear, given this risk and the vulnerability, what specific safeguards will our State Department of Health implement to prevent these disparities and ensure that accountability is there if early data, because we are in phase 1 with the Vermont, I guess, with the cohort 1 and other 6 states are doing. What do you have your plan if early data suggests the model is not meeting its cost and equity goals? And also, why do you think our state was selected first as a cohort 1, if you could answer?
So I'll answer the first part. Well, I'm going to need help answering it.
Quite an accomplishment.
Well, I will say that the AHEAD model is built off the Maryland model. I mean, Maryland has been so successful for CMMI. It's one of the most successful demonstration projects that's come out of the Innovation Center. And so the AHEAD model is Maryland and or built off of Maryland. And so we raised our hands to go in first, one, because we had most of the tools that were outlined in the notice of funding opportunity. Again, as John already described, it doesn't meet all the needs right now. And, you know, models have to evolve to meet the needs of today. And that's where we are with this model. And so we have the pathway to continue to get those enhanced payments from the federal government. But we also have work to do at the state level to improve some of the parameters that you just, or some of the metrics that you just identified. And as John already mentioned, and I'm sorry for speaking to you, John, we have issues like volume policies that we have to work on. The hospitals have already highlighted the need to address physician costs, even if it's not a lever he currently has access to as an authority to push or pull, or that MDH doesn't have access to. Well, let's think about what that looks like and who should have that lever to push or pull. So we definitely have work to address the current needs today as we think about the future of the model and what the industry needs based on what's happening today. So to me, it's an evolution, and this is a point of time in that journey.
Thank you.
I don't know if you want to add anything.
I mean, the only thing I would add to that that's a great answer is I think some of what you asked is really getting at how are we going to monitor progress as we go forward. And I would say that we are doing quite a lot of work, especially with our partners at CRISP, to build up our data infrastructure. Delegate Hill's question and comment regarding, hey, we can't just look at utilization. We got to look at what are the outcomes, right? This work is going to allow us to stratify our outcomes by clinical subgroups in more sophisticated ways. That's what we're going to need to understand, hey, is our healthcare delivery system working for us writ large, right? We're going to need that data infrastructure as we move forward. But that's really where the monitoring component of this really starts.
So, thank you. Let me follow up on that with CRISP. Since you're going to be tasked with helping with the data, right? Making sure that going to Delegate Hutchinson's initial question regarding the hospitals, right? If someone's not doing well. Delegate Hill, can you tell the committee what your role will be and how you think, you know, it will be useful?
Yeah, sure. Thank you.
I can't just let you sit there.
I was trying. They're doing a good job. I didn't want to interject. So Craig Bem, President and CEO of CRISP, Maryland's Health Information Exchange and Health Data Utility. I think really what a lot of this comes down to is maybe two key points. One is that, as John and the Secretary were saying, this is really a 10 or 15-year evolution, which CMMI looked at and leaned into to create a new model. Part of that evolution was CRISP, was the fact that you all invested, kind of the broad state invested in this infrastructure to move data across different care delivery settings, across different populations, to understand both real-time health impact, but also longer-term trends. And so we're really excited to be part of this work ongoing. The other piece of it is that as we look at populations, it's not good enough to look at claims runouts 6 months later at just certain settings. It's really about, are the seniors we're working with isolated or having trouble getting to food, or did they have an issue with a recent passing of a spouse, or are there behavioral health issues? And that's where I'm really excited by the linkages across data and the governance we have to suppress sensitive data and the ability to monitor, are we actually driving healthier communities, not just reducing volume or increasing number of physicians. I'm very confident we have a remarkable healthcare delivery system. The hospitals in this state are better than anywhere else. The physicians are more talented than anybody else. But the data will allow us to focus on population initiatives and then also make sure that we are improving health, not just some of these utilization measures.
Thank you. Delegate Shalega, followed by Vice Chair Collison.
Thank you. Thank you, Madam Chair. Thank you all for being here. We've had a little bit of discussion here today about physician reimbursements. We know Medicaid is a voluntary program, and it sounds like you've got some spot grant funding going to build some primary care physician services. But would it be better to embrace or investigate an increase in physician reimbursements? Is that why you're not getting an adequate participation from primary care physicians? And, so spot funding centers, as you talked about, may help in that community, but you can't put them everywhere. Have you looked at increasing? Is that why there aren't enough primary care physicians? Because the Medicare, which is a different conversation, Medicaid reimbursements are not high enough?
So in all states, Medicaid reimbursement is the lowest of all of the payers. So it's generally Medicaid, then Medicare, and then commercial payments. That doesn't happen in this state in the hospital setting because of the total cost of care model, but it does on the outside. So not only do we have providers not taking Medicaid beneficiaries, but if they do, capping their panels at a certain percentage because of their revenue mix that they're looking for to keep their practices whole. The success of the Maryland Primary Care Program is because we invested in primary care in such a way that they could take on Medicare beneficiaries. We're now under a head doing that with Medicaid. So we are paying now will be paying July 1st, 103% of Medicare rates. So it'll be an increased payment to what the primary care providers get today. In addition, it'll be a case management fee per member per month. So for every Medicaid beneficiary that's in their practice, they will get dollars to do care management. And then back to Dr. Hill's point about healthcare outcomes, there'll be a quality incentive pool. There'll be an opportunity to get even more money based on the outcomes of the Medicaid patients that they're taking care of.
So you're doing like a PQPP, physician quality payment program that Medicare is using. You're going to do that for Medicaid as well?
It won't be exactly the same, but it'll be an alternative payment model to increase payments for providers. Now, we've already done a crosswalk of the Maryland primary care provider and Medicaid providers, and there's a significant overlap in the providers. What's missing is pediatricians, and pediatricians will be allowed to apply or allowed to participate under a head.
All right, one more quick one, I promise.
Why not? He had 10.
Yeah, if I was smart, I would have rolled them all into one, but then I would have been way too confused. We had a lot of discussion, what day is this? Earlier this week, I think, or last week, I don't know. House Bill 170 is Maternal and Child Health Population and Health Improvement Fund. And, really excited to see you've chosen the optional domain is maternal health outcomes. This committee has, as you know, a real commitment to maternal health, addressing the disparities, the bad outcomes, maternal morbidity and infant mortality. As we've been studying this, I see that it's across many different departments within the Department of Health, The Maryland Community Health Resources Commission has something on this. The Prevention and Health Promotion Administration has something on this. The Maryland Commission on Health Equity has a program for this. And then the Minority Health and Disparities also has a program on this. So, do you track this subject? I'm concerned we're like scattershotting this and we're not centralizing this important program and then being able to track the positive outcomes of what we're doing. Can you give us a list of all the programs within the Department of Health that are funding grants or helps on the maternal morbidity and infant mortality issue?
So except for the Community Health Resource Commission, everything you named, except for the Maryland Commission on Health Equity, but it's staffed by the department, is the Maryland Department of Health. And that's all predominantly under the Public Health Administration. So the Prevention and Health Promotion Administration, Minority Health and Health Disparity is in the department, not under Public Health. But we've aligned all the measures. So everyone's North Star is the same, and we're pushing on the lever the same way, at the same time, but not necessarily in the same way. And we now have, one of the things that didn't exist was a Women's Health Action Plan. Last year we released the Women's Health Action Plan, but there is a whole section on maternal child health and then a subsection just focused on Black maternal child health because of the morbidity and the mortality. So the measures are defined, and even under the domain that we picked for AHEAD will be the same measure that we're already using under the work that MDH is doing with HSCRC, will be the same measure as SHIP, will be the same measure as the Prevention and Health Promotion Administration and the things that they're funding. We also have separate dollars now just focused on behavioral health and pregnancy, since we know suicide is a primary driver of death post-delivery. So we're bringing all those resources they're all under one umbrella now, even though they name the different offices. The only one that doesn't report to the department is the Community Health Resource Commission, but we are tracking along with them on the work that they're doing and how it augments the work that the department's doing for exactly the reasons that you just said.
So I appreciate it. We all have the same North Star, quality health, affordable, and then great outcomes. But again, my question would be, can you provide us with a list of all the programs?
We can. And
how much each one is spending? Because that was part of the question that we had on House Bill 170. It was $24 million that had not been spent, in which case I start looking at all these other programs. And within the, one of them, hold on, Community Health Resource Commission, Baltimore County is getting a maternal grant, which, grant for maternity care, which I think is great. But, again, it'd be nice to have a number. Here's $150 million that we've dedicated under these, 5, 8, 10, 12, however many programs it is. Thank you.
And just to follow up, when you provide that number, right, because these are different programs to basically tackle an issue that we know we have. Maryland was one of the worst states, right? Mm-hmm. We went down from 25 to 19. We went up from a D to a C. Can you also put a lot of what we have done to improve that as well, right? And how we do have data to show the improvement and how the dollars, are worth it. And then also, when you provide this list, if you can provide it with all the different counties where all these programs are and the number of people that it's actually addressing, okay?
All that extra information will take a little time to get it, but we can pull it all together into one report. I just want to say, most of the dollars from the health department are federal funds that come from CDC, HRSA, and SAMHSA as it relates to substance use and mental health in pregnancy. But we'll pull the whole list.
And if you can put that as well, what's federal, what's state, and how it has really helped the Marylanders so that our moms are healthy. Absolutely. As well. Thank you. We have next Vice Chair Collison, followed by Bagno, and then Delegate Riley.
Thank you, Madam Chair. Madam Speaker, welcome. And thank you for your presentation. So part of my multiple questions are, are affirmations and then, leading to ultimately a question. So I heard, Madam Secretary, you say that during COVID, Maryland didn't lose any hospitals. And in fact, I also heard Mr. Crum say that when a hospital is struggling or individual hospitals are struggling, HSCRC is able to support them. So these are part of the affirmation part. Other states, my understanding is during COVID did lose hospitals. So, and in fact, since the model's been in place, we have about 70 maybe hospitals, somewhere around there. And we may have lost one or two over the last decade, but not many, which to me means the total cost of care model is working. Yet we're hearing from MHA, they're very concerned about the HED model and that it's not going to work any longer for them. And you've already addressed some of the questions around physician cost. And I've heard you, again, affirmation, say that you are willing to work with them on how to accommodate that and make them whole there. But you only regulate a part of the hospital business. So, and they have other unregulated spaces as well. Madam Secretary, I heard you say some hospitals own physician practices, which I'm assuming are unregulated. Can you speak a little bit to the relationship between the global budget and regulated space and unregulated space, and how do unregulated spaces get financed?
Yeah, absolutely. So, lot of yeses to your to the affirmation portion of your question. So, regulated. When we talk about regulated versus unregulated costs, right? Historically, HSCRC has funded a certain set of costs really around the operation of a hospital. Again, the largest portion of what I think any reasonable person would say is critical to the operation of the hospital is that's not regulated is the physician cost piece. When we talk, but hospitals exist within, kind of broader legal entities, right? Health systems, et cetera, that may kind of own and operate many other assets within their system. What we do is, and this goes a little bit to Delegate Bhandari's question about how do we monitor things, right? Well, historically, we've mostly focused our data collection and our reporting around those regulated costs within hospitals. We can see that right now, reimbursement for those regulated costs, we're back up to kind of historical levels within the model of about 8% positive margins, right? But we can also see, right, outside of those regulated costs, there are many, many cost pressures that we are monitoring and concerned about, right? We don't have, in all cases, direct levers, right, through the regulated, through our regulatory authority to push up on those, right? But what we have done a lot of, especially over the last year, is start to collect a lot more data on cost drivers outside of that regulatory space. Physician costs is a major undertaking in terms of just understanding apples to apples. What are the costs and drivers? What subspecialties are impacted? What regions are impacted? What types of hospitals are impacted, right? Because one hospital might operate by a different staffing strategy than another, right? So those types of things are really underway. But we're also looking at, for example, what are the other costs that a system might incur or allocate, right, across their regulated entities and so forth. So it becomes a pretty complicated financing picture that we are rapidly ramping up our data collection to be able to parse out so that we can more quickly spot and react to cost pressures as they evolve and develop across the system.
And are those calculations going into the ahead model calculation to make sure that, you're trying to meet the needs of the hospitals, I guess?
Well, certainly all of those costs do contribute to the total cost of care, right? So I would say we've long had at least on the Medicare side of the universe, we've long had a very good tracking at this like high level global picture of like what is the total cost of Medicare fee for service in the state. What I'm talking about is like parsing out the costs over different kind of portions of the healthcare delivery system, and quite frankly, understanding, as Craig mentioned, we've got to understand more granularly beyond Medicare fee for service, where are the costs hitting for Medicaid, commercial insurance, right? They hit those parts of the market differently. So all of this is work that is underway. They will be, part of kind of monitoring and performance monitoring and policy development really throughout the AHEAD model. But I would say just generally as a state, right, we need to have visibility over all the different moving pieces of this increasingly complicated healthcare landscape.
Thank you for your work.
And just, to follow up on that, the cost of physician, the salary to hospitals, it's enormous, right? And I know that you don't regulate the physician salary and the cost. However, you need physicians to run the hospitals, right? So we do need to figure out what that cost is and take that into consideration when it comes to, the rates and how we can help as well. And I know that I will be having a meeting with the hospitals and with you. You don't know that, but I will. I'm going to bring you both to the conference room. And I like to sit down with both of you because I know you have different data. And it should be the same. And I want us to come up with some language that I can actually amend one of the bills I have that will basically look at the cost of the physician's salary and what we can do as well. So I hope you're open, both of you, but I look forward to it, but it's going to happen. All right, so let's go next to Bagnall. Delegate Bagnall, followed by Riley and Delegate Olson.
Thank you, Madam Chair. Thank you, Madam Speaker, for being with us today. And thank you to the panel. I just wanted to make sure that I'm understanding, as I understand it, the total cost of care model was really looking at those cost containment as well as health outcomes. And the AHEAD model is really getting us, it's the next evolution where we're getting more upstream and we're looking at how we can really expand our primary care, which we did under Maryland PCP, but getting more upstream so that we're in more community-based care. And I think the concern that we're hearing is how, as we do see the investments in population health and better health outcomes, and we see the incentives for those improved outcomes, how that impacts the hospitals, whether they have a role in investing in community health, because we know that everybody benefits from better health outcomes. But I think there's just not an understanding of sort of how those dollars are flowing and how those incentives are being recognized with everyone's role in population health improvements.
So I would say the expectation is that all, the hospitals don't fund this work. I mean, they fund some of it, but that's not the expectation. And what we've been doing at the health department is we've been working on a mapping exercise for the last 6+ months, looking at everything that we fund at the state level, and how do we think about what we fund to align it with the work that's happening under AHEAD. So, for instance, we look just in public health services in the Prevention and Health Promotion Administration, and I assumed what you would describe, that it was mostly upstream and primary prevention. Well, the majority of the dollars are actually clinical, and they're clinical funding initiatives in the hospitals in many cases. And so we've done that mapping exercise. We've broken out by clinical, behavioral, social, and there's another bucket, I'm blanking on the fourth bucket. But we've started to look at our own dollars and the investments that we're making in the community to do what you're doing. We're now doing that exercise with the Behavioral Health Administration. We've also done it with the MCOs. So we have a good landscape of what's funding. I think what's funded locally to drive improved health outcomes. I think the problem is it's not coordinated. And so that's where we need to get to under AHEAD. And how do we leverage what the hospitals are already doing with what's already happening in the community and bringing those together? So the expectation is not that AHEAD funds all this work, but how do we bring alignment at the community level to all the work that's happening at the community? And we can share, we're not quite done with the mapping exercises, but we're close to completing, at least on the health department side. I think there's an ask to the hospitals to participate as well in that exercise. But we are actively doing that now, and that will be part of the population health activity at the community level.
Delegate Riley. And the last question will be Delegate Olston, because we have the hospital panel and we still have the ER wait time. Okay?
Thank you, Madam Chair, and welcome, Madam Speaker, for being with us, and Secretary and your panel. I think my question kind of goes back to Delegate Traveris. I didn't really hear the answer to her question, so I'm going to, ask it maybe in a different way or what have you. But, when you're doing the total cost of care, we talked about the physicians, that's not part of it. But for aging equipment, I know in my county, they have, a large piece of equipment that they keep asking, can you get us any money for this? Because it's a piece of equipment that's getting old. And to help our patients and for good outcome for our patients, they need the equipment, for the hospitals to use. And there's a lot of equipment in our hospital. So in that original, cost analysis, is there actually a percentage of money that they get for aging equipment? Or is that something they have to get on their own? If it is, what are other resources that they could possibly go to? Or we as, legislators can dig into a different pocket of money?
Yeah.
So
that is included within, typically is included within, if it's in regulated space, is included within their global budgets, and the global budgets do account for depreciation, et cetera. And then over and above that is there is a policy mechanism for large capital projects over $30 million to be eligible for additional funding. Now, there's an expectation that there's other funding sources typically for those types of projects, but a good example of that is the Easton project that was recently approved. So that was financing that was added through an increase in their global budgets. I think.
That formula where to them originally in the budget for the depreciation have you, under the AHEAD program, are you increasing that so that maybe they can have enough money coming from?
So it is not line items.
Okay.
So the global budgets, just to be clear, are not line items, right? So we do not, for example, say, this much money has to be allocated to capital, this much money. Those are business decisions of the hospitals, right? What we do is every year, if you bear with me for a moment, we set a global budget as, back in essentially 2013, right, based on the costs of the hospital at that moment in time. And then over, every year, we account for inflation, right, and then expected volume growth within the hospital. So we make adjustments on that base every year. So contained within that base is money to support capital, et cetera. But we do not specifically line item and say, hey, look, you hospital X have to invest X amount in refurbishing that piece of equipment or buying a new thing over here, right? Those are business decisions left to the hospital.
Yes, and you usually don't ask questions, so absolutely.
Thank you. Yes, so you said that there are other resources that they could go to. Can you provide that to the committee, a list of places that we could actually give to? I'm sure they probably know it, but it would be nice for us to know that as well, to where they can, because obviously they don't have enough money to pay for the aging equipment for those to be replaced. So as their legislator, I would like a list of things that I can reach out to say, hey, would this be a certain area to where we could reach out to you to get additional money to pay for this piece of equipment. So,
yeah. So and again, we can absolutely
thank you.
Come up with that. I would just say that policy that I mentioned, right? That adjustment that's available. It's typically not, replacement of equipment is probably not going to hit that threshold. It's usually, hey, we need to build a new tower. We need to, recapitalize a portion of our hospital. Right?
Thank you very much. Thank you.
And the last question for this panel is Delegate Olston, and then we're going to move on to the Hospital Association on the AHEAD model. And for planning purposes, then we're going to do the ER department wait times, okay? As you know, Maryland has the worst wait time in the nation. Some of our friends have to go to a 20-minute meeting and they'll be back. Just to let you know, it's not meant as a disrespect as well. So Delegate Olston, you have the last question.
Thank you. I'll try and make these 3-1. So my question is really centered around health equity and health equity zones. We previously had or still have health enterprise zones. I want to know how this model will account for those prior funding mechanisms, how we're going to encourage it, and what are we doing in preparation of any potential jeopardy to federal funding that may or may not make its way to the state if this model is dependent on that?
So we have not looked at health equity zones in particular and the work that the Community Health Resource Commission has done just yet. That's one of the things that will happen at the local level. As I said, when they do, there's a statewide health equity plan, and then we'll have regional plans in partnership with their hospitals, since hospitals have to submit health equity plans. And so that work will happen locally, so we're not there yet, so I can't speak to more detail, but that's certainly the goal in areas where there is a health enterprise zone, back to how do we coordinate all these resources in a community so we can maximize the outcomes related to those dollars. As far as the second question, it's certainly something we're watching and waiting. As many of you know, this was a roller coaster week, and we just don't know right now. There's been so far a lot of interest in DEI programs, and so at least the world, according to Laura, I think any program that has equity in it will be maybe a fast follow, but we're certainly tracking that and doing some planning in case of, at least at the Maryland Department of Health.
All right. I want to thank you for your patience as we ask the questions, right? It's a complicated model. We need to learn it. We also need to pace ourselves because it's, it's going to last, once it's implemented, 9 years and then 5 years after that. So you're looking at maybe 15 years. So thank you so much for coming. I know this is not going to be the last time we'll have you in the hospitals here. We're going to hear from the hospitals next. Thank you very much.
Thank you.
So next we have the Maryland Hospital Association. We have the president and CEO of the Maryland Hospital Association, former Senator Melanie Griffith. We have the president and CEO of Frederick Health, and is also a board member. And in addition to that, we have the vice president of healthcare payment and the senior vice president of government affairs. Welcome.
Good afternoon, Madam Chair, Madam Speaker, Madam Vice Chair, the members of the Health and Government Operations Committee. It's a pleasure to be here with you all. It's been a minute. So it's good to be back in Annapolis and definitely good to be back in the House. I was with my former colleagues in the Senate just a little while ago and shared with them it feels very different from this side of the room. But I want to thank you all for your leadership on healthcare issues and your interest in the health of hospitals in our communities. I'm joined, as Madam Chair just mentioned, with a talented panel of subject matter experts, so I'm going to keep my comments very brief. Just wanted to share with you all that in the years since I last served with you all, I've traveled across the state and met with all 60 hospitals and health systems that make up the Maryland Hospital Association. And one of the things that I learned is that there are committed people all across the state who were eager to talk about the care they provide in their communities. We have folks that are showing up 365 days of the year, 24 hours a day, 7 days a week. They suit up, boot up, and show up to take care of the state's most vulnerable. They see our community members when they're tired and hungry and scared and in pain, and they show up and take care of them. And the leaders of those hospitals are excited about the care that they're providing, and they welcome opportunities to do new and innovative things. But they are, in a sense, constrained by resources. And so as I've talked to those hospital leaders, I've heard from them excitement about the AHEAD model and the opportunity that it presents. But I've also heard, and I think the Secretary said it just as well as anyone a few minutes ago when she said models have to evolve in order to meet the needs of today. So as our panel talks about the AHEAD model, I think that's what you'll hear through our remarks. We're looking forward to, and Dr. Crum mentioned how often we meet. They probably hear from me more than they care to. We're talking with HSCRC and MDH probably a couple of times a week, and we are committed to partnering, but there are some things that we can all work on together to make the state more effective as Maryland continues to lead. With that, I'll turn it over to the Senior Vice President for Care Transformation and Finance, Tequila Terry.
Thank you. Good afternoon, Madam Chair, Madam Vice Chair, Madam President. My name is Tequila Terry. I'm the Senior Vice President of Care Transformation and Finance at the Maryland Hospital Association, and I'm delighted to be with you. Members of the committee, we have a few slides we're going to walk you through just to give you some additional perspective on the AHEAD model. So we'll start by talking about our mission. So at the Hospital Association, we really are designed and guided by our mission, where we want to serve hospitals and health systems through collective action to shape policies, practices, financing, and performance, really with the important goal of advancing health care and the health of all Marylanders. We have 60 hospitals and health systems across the state that we work with, and so they're really excited about this opportunity to talk about AHEAD and think about what it may mean for the health of Marylanders. As we think about, really what we want to convey to this committee, what is really going to be important is the focus on this idea that if hospitals are healthy, communities can be healthy. And so as we think about, the AHEAD opportunity, this is really a pivotal time in Maryland's healthcare system and our journey to really pause and think about the longstanding issues we've had in the state and how we can improve and build upon those things. And I'm really heartened by the prior panel with MDH and HSCRC to hear them acknowledge some of the concerns that the hospital field has raised. So as we, there we go, thank you. So as we think about the AHEAD model, this isn't new news to any of you. You have hospitals that are operating in your communities, serving your constituents, but we thought it was important just to start with a few important notes about what hospitals do. First, hospitals in a year serve over 5 million lives annually. And they're caring for, people in inpatient admissions, emergency care, outpatient services, delivering babies, treating people who need emergency care. And they're doing this 24 hours a day, 7 days a week, 365 days a year. But they're not just focusing on treating illness, they're also focused on building communities and making communities healthier. In fiscal year 22, hospitals invested over $2 billion in community benefit programs, including access to health care, housing, food security, transportation programs. And so these efforts are really designed to get at some of the root causes of poor health and advance health care and health for all Marylanders. As you all know, they are the backbone of Maryland's economy. They employ over 200,000 people across the state, either directly or indirectly, and are contributing $35 billion in economic impact every year. They also are focused on caring for Maryland's most vulnerable people. No one is turned away due to their inability to pay, including over 350,000 people who are uninsured and even more underinsured Marylanders. And finally, Maryland hospitals, as you've heard, are a national model for healthcare. It's what the AHEAD model has been built on nationally. And so that experience is something that we're proud of and we wanted to highlight at the outset. So it's also important to note that Maryland hospitals really have a long history of success in the Maryland model. They have been focused on driving innovation under the unique healthcare payment reform system we have, under the fixed global budget system that Dr. Crum and Secretary Herrera-Scott just talked about. And through that system, both in the all-payer model and the total cost of care model, hospitals have generated over $4.6 billion in savings to the Medicare program. And they've done that while maintaining top-tier, high-quality medical care across the state. They've also focused on reducing disparities in unplanned readmissions, preventable admissions, and have performed timely follow-up by race and by setting of care, making sure that particularly areas that experience challenges with socioeconomic conditions have services that can be provided. So the AHEAD model is going to build on this legacy with the hospitals with even greater focus on equity and population health, and really will create new opportunities to work across the state to improve the health of Marylanders. And so across the state, you can see, hospitals here are working all over the state really to set up and provide innovative care. And really what hospitals do on a day-to-day basis is what you see here on the slide. There's a portion of what they do called acute care. And really what that is life-saving interventions. So think about the injuries that happen every day of the week: car crashes, heart attacks, strokes, overdoses. They're taking care of people 24/7, 365 days a week. And they're helping people manage chronic conditions, providing technology, providing specialized care for people like me who need oncologists and who need specialized services. The hospitals are there for families like mine. They provide community and wellness services. They promote healthy lifestyles through campaigns on nutrition, exercise, smoking cessation. They provide screenings and early detection for chronic diseases like diabetes and cancer. And they spend a lot of time addressing those upstream factors of health, social determinants of health, and partnering across the healthcare spectrum to make sure that everyone has access to services they need. They lead vaccination drives, and really, especially during the pandemic, we saw really stepping up to make sure people had the care to prevent disease outbreaks. And so we want to make sure that important work continues, especially as we move forward on the AHEAD model. And we have an opportunity, in this moment to think about how do we build on that work. So the AHEAD model, as you heard in the prior panel, really creates new opportunities to develop partnerships, to share accountability across the healthcare spectrum, and really to reinforce the importance of population health and health equity. And so as we think about what the hospitals will be doing in this space, we wanted to talk a little bit more in detail about each of these. So in population health, hospitals will play a really critical role leading interventions that focus on identifying populations that are most at risk for poor outcomes, developing interventions that really target populations that have worse outcomes than they should, and really coming up with strategies for how to improve, how to coordinate care, not just in the hospital, but again, across the spectrum. Hospitals will also be focusing to a greater degree on health equity. Each hospital will create health equity plans in alignment with that state health equity plan that you just heard about, really to demonstrate how equity is being incorporated in hospital operations, in multiple strategies and services across all of the hospital lines of business. And then partnerships. Hospitals will continue to work with primary care, with behavioral health resources, with post-acute services across the care spectrum to make sure that there is care coordination and to ensure patients get care at the right time and in the right setting. And so as we think about our opportunity ahead, no pun intended, we really want to ensure that, maybe it was a little intended. We want to ensure that hospitals are sustainable because communities rely heavily on the services that hospitals provide. And so what we want to articulate is that, the AHEAD model really is going to focus tremendously on increasing resources in primary care. And that's the right thing to do. We need to expand primary care. It's limited in some communities, but it will take some time to build up that infrastructure and realize the promise of the care transformation and the expanded access that we want for everyone. And in the meantime, hospitals play this really unique role in communities. They continue to be resources that people can rely upon when there isn't any other option. Again, they're there 24/7, 365, providing acute care and complex care that people need. Care that goes above and beyond what primary care is intended to do. And care for people, again, who don't have other options. And so hospitals have to be sustainable to provide Marylanders with a full spectrum of essential healthcare services. And so as we think about what it is specifically hospitals need as we move to AHEAD, it's really about policies to ensure that they're prepared to continue providing that 24/7 access to communities. And there's really three key areas that we want to emphasize. First, we want to make sure that they have sufficient resources to support our growing and aging population. We also want to make sure that there are efforts to support the need to recruit and retain a skilled healthcare workforce. And finally, we want to make sure that we have world-class facilities and capacity to support people across the state, the capacity that needs to be modernized and meet the needs of today. And so as we think about the population, our population in Maryland is growing. As I said, it's aging. You can see here that it's becoming increasingly complex with multiple chronic conditions. By 2030, the percentage of our population that's going to be 65 and older is expected to grow to nearly 20%. And so naturally, we're going to see an increase in demand that will mean more resources, more support is needed. And so hospitals have to be prepared for the changing healthcare needs. Additionally, as I said, populations are, we're unfortunately confronting a situation where there's going to be increased burden of chronic disease and higher spending because of that chronic disease. As you can see here on the chart, the number of Americans with 3 or more chronic diseases is projected to increase substantially by 2030. Heart disease is going to continue to be more prevalent. And in Maryland, the percentage of the population with prediabetes is going to reach 30% of our population. And 15% of the total population is expected to be diabetic. And that's even worse for our seniors. So if you think about the people who are going to be needing hospital care, they're going to be older, they're going to be sicker, they're going to be more complex. When it comes to the facilities and the capacity, the AHEAD model creates an opportunity to revisit policies to support hospital modernization and ensure healthcare infrastructure keeps pace with evolving needs. Hospitals need to be able to perform routine upkeep of hospital facilities, really to make sure that patients, when they come in, they have safe, functional, and efficient settings. We also need to make sure that hospitals can improve and expand their capacity. So again, if we think about the future and what we know is coming, it's that increase in population size, that more complex population. So making sure that we're preparing for that now and safeguarding quality for all patients. And when it comes to the workforce, we have to make sure that hospitals can recruit and retain the best. That's what we deserve in the state of Maryland. Hospitals need skilled physicians, nurses, staff, and staffing has been a challenge since the beginning of the pandemic and continuing now into the post-pandemic years. Labor costs have grown by over 19% since 2019. And this rising cost of healthcare staff has to be addressed to prevent shortages and to maintain care quality. Policies have to be designed to make sure hospitals can, again, attract and retain the critical staff members that will support the patients that we know will need those services. And finally, as we prepare for the AHEAD model, it really provides an opportunity to further deliver the promise of healthy communities and healthy hospitals. We can do both. Healthy hospitals and healthy communities, really, we can focus on the initiatives that we just heard about in the prior panel, initiatives to improve care delivery and outcomes. We can design new population health interventions, set goals statewide. We can develop a state health equity plan and have hospitals aligning with their hospital-specific health equity plans. We can set partnerships across the healthcare spectrum that enables better care coordination. To do that, we have to have healthy hospitals that are ready and able to operate in that environment. So we have to have the policies, the regulations, and the legislation to underpin those goals, to ensure that hospitals have resources to support growing and increasingly complex patient populations, to make sure that the facilities are modern and that they can address the routine capital needs, the routine maintenance that is needed in buildings. And we're talking basic stuff like HVAC upgrades. We're talking about elevator maintenance. We're not talking about big things, but we're talking about the most basic fundamental needs that hospitals have to be able to care for patients and maintain facilities. And then we're talking about making sure that they have the ability to recruit and retain essential physicians, nurses, and hospital staff who are so critical to the mission and the foundation of care in our state. And so, hospitals have been operating in an environment where they've been resource constrained. It's been very difficult, to operate, especially in these post-COVID years. Many hospitals have experienced negative operating margins, and hospitals need to be shored up as we move to ahead. This will enable them to continue their core mission of delivering acute care services, and that will require HSCRC and our colleagues that are in the state agencies to make policies that will support the needs that, again, we know are coming. And so the AHEAD model offers this tremendous opportunity to really be deliberate about our planning and our preparation to ensure that Maryland has the best healthcare environment in our hospitals as is possible. And so with that, I'll pause here, and I will turn it to our board chair, Tom Kleinhansel, to give you some perspective from a hospital operating today.
Started, there was some confusion with the slides. You have them. Andrea sent them to you. Go ahead. But we were able to follow it, and you did really well. Go ahead.
Thank you. Thank you. Good afternoon. How are you all? I'm Tom Kleinhansel. I'm the president and CEO of Frederick Health, Frederick, Maryland. It's good to see Delegate Kerr. Nice to see you. I also am the chair of the board of the Maryland Hospital Association. I have been in Maryland I'm in my 21st year. I don't say that to self-aggrandize. I say that to tell you I've been around about 50% of the life of this waiver. That's making me feel old. But I've also been involved in 2 other updates to this waiver. I was intimately involved in negotiating the updated waiver in 2014, and I've watched this very closely for the last 20 years. First, let me start by saying that the hospitals in this state have achieved every goal that was set out for us through these updates to these models, reducing complications, reducing readmissions, reducing costs, saving the state payer and the federal government lots of money. That's all been very good. I'm proud of that. It's allowed me as a CEO to free up my time and attention to think about things that are creative in my community, to do things I probably wouldn't have thought of doing before, in terms of investing in public health, investing in primary care, investing in population types of things. And that's very good. I think the secretary did a fabulous job of educating you a bit on what this system does to protect people in Maryland, sharing in the uncompensated care, making sure we have access, those sort of things. Those are very, very important elements of this system. I applaud that. I also want to give credit to the secretary and the executive director. They didn't get into all the details of the negotiation of the AHEAD model, but they have with us. And there's some things in there that are really good. The savings targets. When you just came through COVID doing what I do for a living, you want some ability to smooth data. So there's not just one aberrant year outlier that throws the model off. They've been able to negotiate smoothing the data a bit. So I just want to give them credit for some of the elements of this new model that they negotiated. I think they're good. That said, I've watched this on 2 other occasions modifying this waiver. The difference that I see in terms of a moment in time where we were then versus where we are now is the other 2 times we negotiated this waiver, the hospitals in this state were in much better financial condition. Major difference. So we actually, there's many references to COVID a little bit ago. And if you actually stop and look around, yes, it did protect us during COVID, and we didn't have hospitals that closed. But when you look on aggregate how we're recovering as a state in terms of a set of hospitals, we're recovering slower than the rest of the nation. Let me be very clear. Our economics are improving slower than other hospitals around the state. They have the ability to negotiate rates. They've negotiated those. They're pushing their revenue up faster than we are as hospitals. So while I'm very grateful for the temporary relief we've received as a hospital, certain hospitals in Maryland, for some of the economic conditions we're facing and some of the catch up on inflation that the state's done, we're not there yet. We're not out of the woods yet recovering from COVID. We're still dealing with post-inflationary heartburn. We're still dealing with runaway labor costs, those sort of things. This workforce issue is real. We're having to make investments in local communities to build and grow our own workforce. Everybody that's out there that's a vendor that I deal with is passing their inflation on to us, right? We're the end of the food chain on inflation. We have to experience it because we have to buy. 50% of my budget's goods and services. So this is real out there. I'm delighted to hear the executive director talk about some of the policies that we need to address here and now. My encouragement on that front is to have those done in short order, because my board has to make a decision whether or not we're going to go into this willingly before I do another budget in 2026. So we've got to get market share straight. We've got to get capital policy straight. We've got to get things like growth policy straight. We've got to get those things addressed in this state soon rather than later. I think that would calm down my peers around the state relative to going into this with open arms and willingness to participate, to grow, and be successful in this model. So I want to just comment quickly on this notion of regulated, unregulated. And what I want to say there is that this, we're living by the rules that were created 40 years ago. There was this notion of what's regulated and unregulated. And as a CEO, I don't sit around and think about regulated and unregulated, nor do my peers. We sit around and think about how to meet a mission of a hospital and take care of a community. That's what we do. Where I'm going with that is this notion of what's regulated and costs. The definition of what's regulated today does not reflect the cost of running a hospital. That's the Madam Chair's comment, I hope earlier, that we need to address that, this physician cost issue. So I can't run a hospital without anesthesiologists, radiologists, ED doctors, infectious disease professionals, respiratory, pulmonary doctors inside the four walls of the hospital. And 4 years ago when we started this, those doctors came to the hospital and participated voluntarily. We didn't have to compensate them for that, and we didn't have to subsidize them for that. We do today. 80% of the providers in this state are employed by hospitals, health systems. So we have to keep that in mind. And with all the investments that are noble and directionally, aspirationally sound to invest in primary care, that's a great thing. But don't forget that the fastest growing part of what's going to happen when people get older is tertiary care. What's going to happen inside hospitals? So we're going to need facilities. We're going to need capital investment. We're going to need beds. We're going to need bigger EDs, all that stuff. That's all within the regulated space. So we got to get rid of this distinction a bit, or broaden the definition of what's regulated cost, in my view, because what we've done traditionally, we can't just carve out the things because it's expedient to say we don't regulate that, therefore we can't pay for it. That's my view, N of one. So with that, I appreciate the notion too, and I do think this is built in a very positive way. These flexibilities that the executive director commented on, there are flexibilities. And to the fine Delegate Hutchinson's comment about what do you do if somebody goes south, the premise of the question, those flexibilities are there, but they have to use them, right? They have to use them. They have to put them into action to make sure we stay stable. I'll just give you my take. I'm going to just put my Frederick Health hat on for a minute here. We had 200 days cash in our bank savings account before COVID. We now have 145 days. So we've spent down 65 days of cash. That's because we've had a negative operating margin since October of 2021. So we have not made money until last month was the first month since then we actually turned back in the black. And then on Monday morning, I woke up to a phone call that my hospital shut down with a ransomware attack. So I've got 100% of my staff working on paper right now, so that's another unbudgeted expense I've got to figure out what happens as the fallout of that. So that's the reality that we live in every day, these kind of untoward events. Where I'm going with that is balance sheets are important. We can't go down much forward more because you got to have flexibility to deal with a crisis. If we had another COVID right now, and I dropped as many days as I dropped during the first COVID, I would default on my bonds. We can't set a threshold for how much cash hospitals ought to have by picking the lowest common denominator, which is your bond covenant. we got to set a higher bar. We got to set a higher bar for what people need for emergencies, that kind of thing. So I'll leave you with that. Am I optimistic about ahead? Yes, absolutely. And I do think all the things we heard are aspirationally and directionally very sound. I look forward to participating in it. This is a 10-year agreement. That's a longer agreement that we've signed in the past. So we got to get this right before we go into it. At least that's the stability I think we're looking for. And to do that, I think we've got to work really hard in the short term in terms of policy clarification in the next 60, 90 days so that we understand what we're getting involved in. I've watched, again, this twice. And twice I've watched us go into the agreement, get a year or two in before some of this policy is worked out. And it works a lot better if you do it up front. We want assurances up front that we're going to be able to address the important things that we've laid out so that we can go into this with open eyes and that we know we can work hard to help it be successful. So thank you. I appreciate your time.
Thank you for sharing that.
Thank you.
Yeah, Madam Chair, your good friend Patrick Carlson is here in case there are questions, so.
That's right.
I'm going to open it up for questions now. I see Delegate Hutchinson, Taveras, Shalega. Okay.
Thank you, Madam Chair. This is for the hospital president, especially since you acknowledge that you've been around for half of the waiver period. I've been in healthcare for 25 years before I became a proud member of this committee. And there's always been this question I've always wanted to ask, and I never knew who the right person was to ask it to.
That's me.
And I always heard about the waiver, us being under the waiver state. If the waiver's so great, how come 49 other states aren't clamoring on the door to say, I want to be part of it too?
Great question. Let me give you my perspective. I've worked in 3 other states. Successful health systems. But it's very... I like Maryland best, I guess. Let me put it out there. I do see that we share in the profound nature of equity of care and work hard on that. I do see that uncompensated care is equally distributed in this state. I worked in a state where, in a city that had, we were the safety net hospital, and that was really tough to make ends meet all the time. This is... generally speaking, in my first 17 years of life in Maryland, we did really well in this system, economically. When I worked in a state in New England, the cost shifting is challenging. You're jacking up your rates on your commercial insurers to help compensate for what you're not getting on the government payers. So there's this whole other notion of work that goes on to try to do that. So it's why others aren't doing it. I don't, it's independent nature of people running businesses, right? Health systems that, what you give up here is the ability to go negotiate directly with the commercial insurers for all your work, right?
So I understand what you're saying is, well, as its warts and challenges, you like being under the waiver system.
Yeah, I do. I've seen the benefits of it. Yeah, I think well, let me put it this way. It protects you on the downside, which it did for us early in COVID. And it used to help you more on the upside. But I'm in the fastest growing county in the state right now, and it's not keeping up with our growth. So there's some things we got to improve, and I think that's been acknowledged by both the state and us. But overall, I do think it works. Yeah, good. I do think it's a safety net. I do think that it puts resources heretofore in the past where they need to go. I think there's some reallocation that needs to occur. I think there's some policy development that needs to happen. But overall, yeah, I do.
Great, thank you so much.
Hope I answered.
Appreciate it.
Yeah.
I have Delegate Taveras, then I have Shalega, and then Rosenberg.
Thank you, Madam Chair. And again, I don't mean to harp on the same topic, but I do value your point of view, because how can we truly provide sustainable health care if the infrastructure, which is the hospitals, are breaking down, right? there's a merengue song that says from Juan Luis Guerra, it's like, yeah, I'm going to have sugar in my insulin. You know what I mean? Like that they have to put sugar in the IV in order to sustain the individual. You know, who wants that, right? So here's, maybe this is the mathematician side of me coming out. I don't know. The thing is, I'm hearing a lot of QuickBooks. I'm hearing balance sheets. I'm hearing basic algebra. I don't know how deep are you getting. When people throw the word optimization, I don't know what you mean with that. So my question is, are you looking rigorously in developing a hybrid mathematical optimization model, such as a simulation model that will virtually represent the system, testing different scenarios that will create a performance, that will provide performance metrics with a Markov chain that will analyze the state transitions within a system that understands long-term results, which is the long-term outcome of the medical portion of individuals. So this, if you could create a hybrid model, I think that is something we could test fairly quickly, within 69 days, come out with some results, get some min and max. I know you don't need to trust me. Quantum in diversity, in your diversity center, quantum, what is, at the university? No, the question is, are you open to that? Because it's 69 days. We've got to have a result. Quantum can put that together for you. That is what they do.
You got this.
Yeah, I mean, I think in this, I think what I hear is speaking directly to the really the unmet capital needs that hospitals have been experiencing, right? And, you know, it is important to look at really thoughtful ways to assess capital needs. I think our member hospitals are in the best position to assess what those needs are. I think what we heard this fall, we surveyed our members really in the midst of grappling with the financial conditions that they've been experiencing, just to get a sense for what's happening with them and their deferred capital purchases. And all of our respondents replied that they had deferred substantial amounts of routine needed capital investments in the last 3 years because of operational uncertainty in the funding environment that we've been in. And so I think you're really touching on something important, which is, you know, the absolute need to make sure, you know, that hospitals have a clear picture of what their needs are, and to have our policies for funding hospitals for those capital needs to be sufficiently responding to those needs. It sounds like that you're presenting something that is very specific and innovative, and I know that our counterparts at the HSCRC are very smart people and would be completely open to looking at that. We have work groups that meet with representatives of the HSCRC and also representatives from the hospital community, and we discuss, you know, innovative ways that we can improve our methodologies for supporting our hospitals. So we'd love to hear more about that. But I think the point that I would want to articulate here is that we really depend on our commission to use the tools that they have in setting our global budgets and our rates to make sure that they are keeping up with the cost pressures that we're experiencing. And that is really the take-home message that, you know, that I'm hearing from our colleagues, is that we need to make sure that those levers, those tools that we have are really being responsive to the needs.
We can talk offline.
Yeah.
On what that looks like and what would happen.
I know the speaker has to leave us for another meeting, but I want to thank her on behalf of the Health and Government Operations Committee for being with us today. And thank you for allowing us to do this work. Sure. Thank you. Thank you. We're going to go next to Delegate Shalega, followed by Rosenberg, then Olsten.
Thank you, Madam Chair. Thank you all for being here. We had a lot of discussion about the cost of delivering care. There are 3 items I would like you to ask your 60-plus members. Number 1, what are their energy costs? We had a presentation today in Baltimore County delegation, and the superintendent told us her energy costs are up 24%. So I'd like to know, what the policies coming out of Annapolis have done to your energy costs, and are you projecting even, further increases going forward? Number 2, what are the advertising budgets in your 60-plus hospitals? I was surprised to see one of our Maryland hospitals advertising while I was watching the Super Bowl. So I just wonder what those costs are. And number 3 would be travel expenses and conferences. So we can look at, some of these pressures on your budget from energy and other items in your budget that HSCRC, I don't think is looking at as they're looking at your budgets. Thank you, Madam Chair.
All right. I have Delegate Rosenberg, followed by Alston.
I realize you can't be, you're limited in what you can say since you're about to negotiate with a new administration in Washington and a new Congress. But what is your sense of where the federal agencies are with regard to our unique system? Is there anything you can say to that?
Well, I'll start and then ask our board chair to follow up if I leave anything out. I think the secretary's response to this is what we would be able to reflect, and that is, at this point, we have a negotiated agreement. The changes that will come as a result of the new administration are yet to be known. It's unclear. And so we're all watching, as you all are, each day as new information comes out and new executive orders are signed. We're watching and tracking that real time with you all, but just don't have a sense yet as to what the impact will be on the work that we've all done for decades in this state.
If I may, if there were to be cuts in Medicaid payments, how does that affect our system? If there were to be cuts.
In Medicaid or Medicare? I didn't hear your question. Could you repeat?
Medicaid.
In Medicaid? Well, certainly it wouldn't be favorable to the environment for hospitals or patients. The funding that is being provided by the federal government, as was articulated by Executive Director Crum, is really critical to the infrastructure of our healthcare system. And so, we rely upon whether it's federal match funding for the Medicaid program or the enhanced Medicare payments to sustain our system. And so it would absolutely be impactful to the state if those things went away.
Thank you.
I have Alston.
Thank you, Madam Chair.
My pleasure.
Okay, thank you, Madam Chair. First, Ms. Terry, I want to thank you for sharing part of your story with us today, and I pray that everything goes well with you. Second, my question is about our funding mechanisms in this state. Do you all believe it has any impact on our ER wait times? I know it's a complex issue, but since we're the only state that has this type of funding situation, we're also the only state with the highest ER wait times in the country. I've always wondered, just from a business perspective, because healthcare is not my background, whether or not there's any correlation or causation with the two.
Well, certainly, I think that is one of the areas that we, through the Hospital Association, in conjunction with our colleagues at the Health Services Cost Review Commission, are looking at. The fact that hospital systems the capacity is capped through the system certainly has implications across hospital input, throughput, and output. I think you're going to hear some strategies that the next panel will be talking about on how we are looking at addressing initiatives in each one of those areas, but it's a fact of the system that, capacity may be constrained in certain areas because of our system. And so that is certainly a factor that should be considered as we think about the ED wait time issue.
Yeah, thank you. And again, thank you. This is a health committee, right? So we know how, important your health is, and you certainly will be in my prayers, okay? Thank you. We appreciate it. Are there any other questions for the hospitals? Vice Chair Collison, it's right in front of me, and I can't see the light.
Well, we know about looking to the left.
Oh, I know.
Thank you, Madam Chair.
You're welcome.
Thank you all for being here. And, Ms. Terry, when you described what our hospitals do, it just makes me so proud. I mean, you are an incredibly successful organization, and we measure the success by the health outcomes of our people here in Maryland. So thank you very much for your work. And, and as I said before, I mean, you've been able to do that work under the old model, but I am a true believer in evolution. Anyone who's seen me at this table for the last 14 years knows that I do not like the status quo. So I think evolution is important. And my question is, number one, two parts. Number one, do you feel like in the ahead model you have the opportunity to contribute information in the evolutionary process that's going to happen through the implementation of the ahead model? That's number one. And number two, do you think and it goes along with it, the data collection that's being required under ahead will help you to clarify what the needs are and what changes will need to be made to make sure that our hospitals can continue to be as successful as they've been?
And thank you, Madam Vice Chair, for that. I too am proud of the work of our hospitals. As we think about engagement, I think is really about your first question. There have been a number of opportunities for the hospital field and broadly across the state, people to engage in the ahead process through work groups. I think where we are now in the implementation process, however, we need much more targeted interaction with the hospitals around specific policies, because there are specific policies that have very specific implications to whether or not hospitals can be successful in the ahead model. So I think that's where we are now, is a point where we need to narrow the focus to some key areas that I described in the slides that really will make a big difference. And we have to approach those with a sense of urgency, because hospitals, are to, the chair or the chair's point, Chair Kleinhansel's point, hospitals are in a planning mode. They have to start looking forward to fiscal year 26. And so they have to have certain certainty about what they're going to get in terms of revenue, in terms of, the policies and implications. So there's a lot of planning that needs to happen even in advance of our January start date. And so we need to be approaching sort of these core policies with a sense of urgency to ensure that progress is made. And in terms of the data collection, I think that it's great to collect data and make sure that we really understand sort of long-term solutions that can be put in place. But again, I want to emphasize the urgency and the need to have short-term solutions as well. It may be that in some areas we need to think about what we can do in year one versus 5 to 10 years later. And so I think we need a strategy that really focuses on the urgency of here and now.
Okay, great. Thank you very much. Thank you, Madam Chair.
My pleasure. Any other questions for the hospital?
Madam Chair, I just wanted to take this opportunity to thank you so much for your leadership, your accessibility, and working with the hospital field. We're so fortunate in this state to have you and to have leaders like Speaker Jones and President Ferguson who keep healthcare on the forefront of issues the state is addressing. So I just wanted to say thank you and thanks,
for your kind
committee.
words. The feeling is mutual.
Thank you.
Thank you so much. So look, we're going to continue this conversation, right? I know we have the ER wait time next, but I know that this is an important issue for the hospitals. It is an important, for the state, we need to get it right. It's an important model, right? I know all the parties involved, and I know that you will all come to the meeting. We will try to start the conversation, see what we could do this session. We have a whole year, right? 11 months before the primary care goes into, it's implemented in January 2026. So my hope is that we can continue to talk, since they have flexibility, make adjustments where we need, and stay at the table, right? And I commit myself to being there and helping out, all right? And I know my committee would do it as well. We all have hospitals in our districts, right? And we do hear when things don't go right, and we do go to the department. So I know they get a lot of calls from us and the HSCRC. And I know that they're willing to work, because I've spoken to them and they're willing to come to the table. So we will try to continue the conversation. We're at the table. And I feel pretty optimistic because we are at the table. If there's a problem when we're not at the table and we're not willing to talk, but everyone is willing to talk. So I think the picture is quite clear. So thank you so much for being here today. And I hope you guys have a blessed evening. I know we still have one more briefing. Okay, so we're going to call Secretary Laura Herrera Scott and the Executive Director of the HSCRC, Dr. Crum, and we're going to call Tina Simmons, who's the Associate Director of Quality Methodologies at the HSCRC. Okay? And as you know, for the committee, we have Maryland is not doing well when it comes to ER wait time. And this General Assembly saw it fit to pass a bill. Delegate Bandari, thank you for your work. They would bring all the parties involved, not just the hospital, not just the HSCRC, but people from the community, to try to discuss the issues and address it as well. So that is why we're receiving this briefing today.
Where does it start? Great, thank you. I'll start us off. Thank you again, Madam Chair and Madam Vice Chair, members of the committee. I will kick us off. I think what we're going to do here is we'll talk a little bit about kind of the problem in front of us, and then we'll talk a little bit about what each agency has done, and then the important work of the ED Wait Times Commission that is being done in partnership with a lot of stakeholders here. So the kind of starting point for this is, as you said, right, this is a challenge that you know, we faced here in Maryland, as other states are facing. Oops, sorry. Temperamental, yes. But I will.
Oh, there we go.
Oh, there we go.
The other way.
There we go. So this is a challenge that we've faced as a state. What I would say is we faced it for many, many years. So to the questions about, you know, whether the model has caused it, I would say, you know, the problem has extended well before the model, and you know, it goes back as far as our data can see, right? So I would really characterize the model as potentially changing the tools in the toolbox for dealing with this challenge going forward. And not just limitations, right? Really thinking about, hey, what can we bring to bear? Because I think in other states, when states have focused and hospitals have focused on solving ED length of stay, it oftentimes does not result in patients getting the right care in the right setting at the right time, right? I think that should be ultimately our goal here. So what I want to talk a little bit about first is kind of framing the problem, right? So this is a multifactorial issue. We've talked about that before. Lots of complexity here. What we've done, at the HSCRC and then now within the ED Wait Times Commission, is really try to break those things down, break down that complex problem into some constituent parts, right? So what we're highlighting here is the emerging kind of picture on what is driving ED length of stay challenges here in Maryland. And I want to highlight a couple of the key factors because these are going to then become priorities for the ED Wait Times Commission as we move forward. Institutional complexity, I put that on here just to say we in Maryland, and we should be proud of this, right? We have hospitals that manage really complex care within their four walls. That does generally create challenges for ED length of stay because as you're managing more complex care in your hospital, you're doing more of that care in the ED. So I do want to highlight that. That is not something that we need to solve for. That is something that we need to accommodate and factor into our strategies. Hospital capacity. So this is really something that I think there's a lot of conversation going on, and it's going to be a major focus for the ED Wait Times Commission. Again, multiple parts to this problem, right? First, length of stay. Are we optimizing kind of and turning over beds in the way that we need to make sure that we're optimizing the capacity that exists within our hospitals? And I really mean that not just within the ED, in the inpatient side, right? Because when you have a bed that's not available on the inpatient side, that patient is going to stay in the ED for a longer period of time, right? Bed distribution and type, right? We don't have beds in all the right parts of the state, right? We need to, again, to my earlier comments, we need to think about this problem in a regional way, right? We need to understand, do we have the right beds in the right places around the state? And then staffing is always a challenge as well. You could have a physical bed, but if you don't have staff to manage that bed, then you're not going to optimize that capacity. And then the last thing I would mention as a major factor when we model out the puts and takes of ED length of stay drivers is ED volume, right? That sounds really straightforward, but we do have across the state hospitals that take a disproportionate share of the ED volume, in their hospital relative to others. That does create bottlenecks and traffic jams within the system, right? There, at the same time, and this is where I think the ED Wait Times Commission approach really makes sense. We've got to take a whole system approach to this, to ED length of stay. There are also many, many non-hospital factors that contribute to the challenges that happen within the hospital. So a couple of the ones that we've highlighted out in our modeling over the course of the last few months here is skilled nursing facility capacity is a real challenge. So think about it this way: as you're trying to discharge a patient, right, from an inpatient bed, some portion of those patients have to go to a skilled nursing facility. If you can't get them there, where are they going to stay? They're going to stay in that inpatient bed, which means that somebody can't move up from the ED, right? So looking at that chain on the post-acute side is a focus of ours. And then on the other side of the equation, right, access to primary care, access to behavioral health care. This is preventing the need for an ED visit because it's reducing the likelihood of a patient being in crisis, right? Additional factors, there are also Other factors that maybe don't rise to the same level of impact as the others, but they're important, and we should be looking at levers to move those as well. End-of-life care is a major one. I would highlight that one. Right? We do a lot of end-of-life care in the hospital setting, and that does pose some complexities there. So I just want to highlight a couple things that we've done at the HSCRC over the last year to really gear up and then drive impact on ED length of stay across the state. So over the last year, we've been working very closely with the hospital community and some other stakeholders as well. I would recognize MIMS here as well as a core partner. To do a couple things. One is collect more granular data about ED length of stay drivers and performance, right? And then two, really work collaboratively to understand best practices that are going on across EDs across the state. I would say that we have some real good examples of hospitals who, through hard work and implementing innovative programs, have driven down their ED length of stay precipitously, even within 1 year of work. So that is really, I think, encouraging here. The other thing that we've done is we've put ED length of stay as a measure that is part of now our quality incentive program for hospitals. So what does this do? It puts some revenue at risk for ED length of stay outcomes. Really, this is intended to make sure that the quality teams at each of the hospitals keep this kind of front and center as a priority as they're doing their work, right? So we have some really skilled quality improvement teams in hospitals around the state. We want to make sure that they're applying their skills and expertise to improving this particular quality outcome. So we've done that work as well. Let me pass it off to the secretary, who will talk about some of the actions that the department has done.
So some of you are familiar with our 1915I services, and those are home and community-based behavioral health services that support youth and their families in the communities. And specifically, it's for kids with severe emotional disturbances whose kids and families are swirling in the system. It provides intensive home services, respite services, family peer support services, and experiential and expressive therapies. The problem is we made the gate to accessing this information too hard, or accessing the services too hard. And one of the things that we've learned early on when I started in this role is, as part of ED wait times, our kids that are stuck in the emergency room and how these services could have helped unstick those kids. So what we've been doing is we have several proposed changes. There were many criteria that families had to go through to access services, and they quite frankly gave up because we made the barriers to accessing the services so high, and this was under the previous administration when they developed the program. In addition, it was only for a small number of people. It was funded at 200 people per year, but I can tell you on any given time, or 200 people at one time, there was only about 30 to 35 families that were in the program, just again, because the program was so complex that they gave up. So over the last 8 months, in partnership with a consultant, we have been working, and stakeholder groups, we have been working on updating the key proposed changes in the 1915I that increases the time frame for face-to-face psychosocial assessment. It expands participant eligibility based on their score differential. It updates the frequency of reviews, and it also removes separate reimbursement for telephonic peer support services, as well as add coverage for youth peer support services, so youths can get their peers helping them through this process. And what that will mean is we will be increasing the number of slots from 200 to over 2,000 slots, and it will be significantly easier for families and kids to access services. So this is an upstream intervention that we hope
families will be able to access, which will keep them from crashing into the emergency room in crisis. I cannot see that. See it on the mouse? Thank you. The next is our expansion of urgent and acute care services. So, we've done a lot of work, as many of you know, on 988, so you have someone to call. But a lot of the work that we've been doing over the last year is on community-based mobile crisis services and actually brick and mortar crisis stabilizations. So we have funded $13 million in last year to really expand the number of mobile crisis teams we have, as well as brick and mortar. So if someone is in crisis, they can call the mobile crisis teams. They'll get deployed locally and try and stabilize the family and the child in the community, in their home, and then connect them to services from there. And in addition, there's post-stabilization care coordination activities to help do that, to ensure they get connected to services. So that's another area where we are working to try, again, get people served in the community and keep them out of the emergency room. So it's in-person support by a team, including a licensed behavioral health professional and often a peer. It's available 24/7, 365 to go to the individual in the community, whether that's at home, at school. Services to de-escalate, assess, and stabilize in the community, as well as warm handoffs, and then continue to support evidence-based youth family response and stabilization model. And this existed, but not in as expansive as we will be doing today. And last year we put out regs. There were mobile crisis services, but mostly for adults. There were very little teams that were able to support kids and their families in the community, and now that's live. And then lastly, we know our people that are homeless or marginally housed have difficulty accessing services and often end up in the ED. And so as many as you know, our assistance and community integration services was a pilot that started in 2017, and it basically provides wraparound support for housing related services and supports to keep people stable in their homes. It was previously funded by the local health departments. You had to be a Medicaid participant that met a specific health and housing need. And it was 900 spaces across Baltimore City, Cecil, Montgomery, and Prince George's County. And there was a study that looked at the outcomes related to the ACES pilot, had a significant reduction in ER, significant reduction in inpatient treatment, as well as stabilization in the community. So we expanded the pilot to better serve the eligible population and identified the $5.4 million general funds. And I think some of you saw the press release that we released earlier this week, or maybe last week, that we did get our 1115 waiver approved from CMS. So now we are able to more than double. It's statewide, all counties, and we will be able to continue to provide wraparound services for people that are marginally housed through this program, keep them stable in their homes, as well as connect them. There's support services that do care coordination and connect them to their primary care services and other services to keep them out of the emergency room. And with that, I'll turn it over to Tina.
Thank you. So as everyone here is familiar with, the ED... Sorry. As you are all familiar with the establishment of the Maryland ED Wait Time Reduction Commission, I'll be brief. Just to highlight our specific focus, we're really looking, as John shared, to really ensure that patients are seen at the most appropriate setting. So we want to provide the right care at the right time, in the right place. We're looking at improving hospital efficiency by maximizing both the flow of the ED and the inpatient areas. improving post-discharge resources to facilitate timely and emergency department and inpatient discharges, and looking at best practices across the system, as well as we are now focusing a lot of time on identifying and recommending improvements in the collection and submission of data. And I will add to that really the data analysis to drive our interventions, specifically regionally and by hospital, as opposed to just across the state. So the ED Wait Time Reduction Commission and subgroup composition, I won't read all of the departments out, but the takeaway from that is really just the complexity of this issue, I think is highlighted by the various backgrounds and participants and levels of expertise that are participating on these commission meetings and subgroup meetings. Sorry. So this is just our visual of the ED Wait Time Reduction Commission. Again, we're looking to improve overall access, implement hospital payment programs to improve clinical care. These incentive programs are typically the lever that we use at HSCRC. Increase transparency and reduce avoidable utilization within the system. So again, the right care at the right time in the right location. Our subcommittees, we have an access to non-hospital care. That is really focused on both primary and post-acute care, with a heavy focus on the transition to post-acute, so palliative care, skilled nursing facilities, looking at what we can do in our processes to address advanced care planning, advanced directives. Our data subcommittee runs along all of our groups, and this is really where we are pulling together all of the data that exists and some new data elements. So we look at a lot of different metrics, and so what we are trying to do is pull all of those metrics together to give us a comprehensive, complete picture of what's happening across the continuum of care. And I think that's a little bit of a different lens than how we've been looking at the data previously. And this commission allows us to access some data sources that we did not have access to prior to its existence. The hospital best practices subgroup is heavily staffed, if you will, by hospital members. And this is where we've compiled best practices across the system that individual hospitals have either implemented or are in the process of developing. And we are sharing and looking at how can we implement these across the system and standardize these to address our hospital throughput. Our hospital capacity operations and staffing group is focused on just those things, capacity, operations, and staffing. But again, we're pulling in all of the data and the work that's ongoing through the other groups to look at how do we create the right capacity across the continuum. And we are looking at innovative ways to increase capacity that exist within the hospital as well as outside of the hospital. So our key priorities, again, really looking at capacity across the continuum. So access to care pre, intra, and post-hospital. The care transitions that occur within the hospital, and that's where our best practices are looking through that whole hospital experience from the ED, intra-hospital, and then how do we transition those patients to post-acute levels of care. This is a very high level of our timeline. So the bill was implemented July 1. We finalized the appointment of our members in September. We had our first meeting in October of 2024. And then we have ongoing calendar of meetings. So our 2025 calendar for all of our subgroups and the Wait Time Reduction Commission has 54 meetings. And I share that only to share the amount of work and engagement and all of the ongoing activities that are planned for this year. We work collaboratively with Maryland Department of Health, as you've seen, and the Maryland Hospital Association. We do have a monthly meeting where we collaborate on ongoing priorities. And then all of the materials and all of our work groups are shared on our HSCRC website for any additional information that you're looking for. So with that, I'll say questions.
Yeah, I'm going to open it up for questions. From looking at your presentation, you're meeting often and different groups are meeting often. So that is really good. Again, we're at the table, right? And I'm going to start with Delegate Chisholm, followed by Bendari, and then Taveras.
Thank you, Madam Chair.
My pleasure.
I think everybody is working very hard. We're 50th to have 50th. It's very frustrating for a lot of people, and I understand. I fear that sometimes we just want to fix so many things internally, and we create commission and work groups, and it becomes so big that we don't fix it. And sometimes I believe that the answer is right outside the door, and we have to engage with the private sector. And I only bring that up because I have sent to several people now a company called Choreo ED. Here's what they've done, because I started talking to them about using AI in a lot of our systems. They called me after I was on a panel, and it seems like they just hit a block door after block door. And I'm like, why are we not engaging with the private sector to help us solve our problems that we've been unable to solve at this point? And I know that it's very complex, and I know everybody's working overtime to fix it. They decreased ED wait times by 42%. They reduced ED labor hours 1,427 per month. They're doing a lot of things right in West Virginia and Denver, and I think they're in New York as well. They're out of Michigan. I just want to make sure that we're always open to engaging with the private sector, because I look at your commission and I agree there's a lot of very smart people on there, but they're also engaged in other things that they're doing. They're doctors, physicians, and their primary goal is to see their patients or whatever it might be. But I just want to make sure, because everybody in here, as the chairman said, is willing to do whatever it takes to help us move this ball forward, because it's important. And I'm good friends with Brett McCone, who's now over at BWMC. He's telling me about patients that are stuck in that hospital, and that stops people from coming in, and we need a solution. And sometimes that solution means we depend on people outside of the government bureaucratic body, and I just want to make sure that we're always open to that. Thank you.
Any response?
Sure. I'm happy to respond. I think that's a fair point, and in fact, as part of this group, while they're not represented on the slide, we've met with a number of particularly data and analytics companies who specialize in kind of looking at key performance indicators and then stratify the data such that you can really focus on, hey, it's this clinical subgroup that you've got to work on, right? I think that we're not yet at the point to say, hey, we've got something that makes sense to scale across the state, and that's partially because when we talk to hospitals, and Tina especially talks to some of these operations teams, clinical operations teams on a daily basis, the challenges and then therefore the solutions that they're going to need to manage those operations, which Choreo really specializes in, are a little bit different in each case. So it's not going to be a one tool makes sense for everybody. But we are, I think, absolutely looking to take advantage of the emerging kind of technology solutions in particular that are going to help us drive performance in the state.
I think the goal is to make sure that we don't have. Bottom line is this: we don't have enough people either labor hours, bodies, beds, and we have far too many people waiting on those beds or those people that in the labor hours. So anywhere where, AI is it's data recognition, right? It's reading data sets and being able to create the most efficient so that the people that are performing the duties that need to be performed by a person is actually doing that and not being caught up in so many repetitive, tasks is what I hear from a lot of people in the hospital. They're doing things that really aren't serving their greatest strength and their talents. And I want to make sure the people that are using their greatest strengths and talents inside a hospital system to get to the people that really need the help. And if we can start to eliminate some of the repetitive stuff and rely on some of the emerging AI and all the technologies coming out. But I do agree with you. I know it's you can't just throw it at it. It's going to take a while. So I really do appreciate that we're trying to, get to that point where we're creating a more efficient system. Thank you, Madam Chair.
Thank you. I have Delegate Bandari next.
Thank you, Madam Chair. It is very encouraging to see that everybody coming together and working. Thank you, Senator Melanie Griffith, for your wonderful leadership when we passed that first tax force bill, and Senator Finance Chair Bidel and everybody, Delegate Kathy Seliga, Delegate Martinez, and wonderful leadership of our chair. And it was wonderful to hear from Andrew from MHA and John from HCRC for what they're doing ahead of this presentation as well. And I'm really encouraged by the progress, like Franklin Square Hospital in my district, making an Adventist Health. And they have been implementing massive operational change and innovative program to tackle ER wait time. And absolutely, some of the key points you highlighted are systematic factors outside, right? Some of the skilled nursing facilities, staffing shortages, and capacity inpatient bed, access to primary and behavioral healthcare, ongoing challenges. And I would like to hear from the panel, so could we use the best practices from other hospitals and some of the measurable improvement that you have seen it to fix these long-term barriers?
Yeah. I'm happy to jump in here. Yeah. So I think there's two ways in which we're doing that. I think one, in collaboration with the Maryland Hospital Association, just convening the operators, right, so that they can share those best practices. We do have hospitals of different sizes, different challenges, et cetera, and I think it is always helpful to create venues where people can share, hey, I'm applying this program, it's working, here's how we've been able to scale that, right? So I think that's important and ongoing work. We are also looking at, hey, what are the kind of common best practices? So not every best practice is going to work for every hospital or is going to have opportunity for every hospital, but there are some kind of common set of best practices that we need to ensure are kind of like the floor, right, of hospital operations. I think we're getting a lot of traction there too in identifying, hey, this is the core set of best practices that we have to ensure that our hospitals are working in great shape. So I think both of those things, we've made a lot of progress over the past year, and I do want to call out that we've got some of the best and brightest clinical operations experts in the country in this state. It has been really encouraging to see them kind of rise to the challenge, share their expertise really generously. I mean, they're volunteering lots and lots of hours when they could be spending that time within their hospitals. That is for the betterment of the entire state, and I just could not be more appreciative of that effort.
The only thing I wanted to add is just that the best practice group that John is referencing has representatives from every hospital in the state or their system level representative, and they are highly engaged across the state in every area.
Julian?
Thank you. And could you elaborate a little bit on systematic factor outside, like we were talking about skilled nursing facilities? They have enough bed, and what is the problem?
So we are just, that's not data that we have typically had access to historically or that we focused on because we are hospital focused. So I will answer that with the understanding that it's very preliminary as we're just starting to look at this. But I think there are a number of factors. Certainly, we want to look at their metrics, their length of stay, we believe is an opportunity. And looking at that, looking at some best practices that potentially we could lend and share with the skilled nursing facilities. And then really breaking down by regional capacity and looking at that through the same lens that we're looking at the hospital factors. That's where we're starting with that, where we see opportunity kind of off the top.
Thank you. I yield, Madam Chair.
Thank you. Delegate Taveras. Oh.
Yes, ma'am. Yes, ma'am.
It will not let you talk otherwise.
Sometimes that's good. No. Thank you, Madam Chair. Okay, let me hear y'all better. Hold on. So it does look like you guys are using data analytics and some of these performance metrics, and so you are already considering. I don't know if you are considering and you're getting data back, but I don't know if you're considering maybe hybrid models that are looking at like the long-term dilapidation of hospitals versus the need for greater tertiary care, whatever. So just food for thought. In terms of the, I'm looking at page 26 for 1915 proposed changes. And the services that you're rendering here, is this only for substance abuse, or does this include substance abuse or only therapy, behavioral services?
It's, most of these children have severe emotional disturbance, so it's mostly mental health services for these children and their families.
So I'll just close. Maybe we could talk offline. As you know, we're working very closely on what we could do with children that are addicted and have substance abuse issues. And we just had a great conversation that I think you might be interested.
Well, to that point, as you recall, when I was here, I think a year ago, we didn't have any inpatient beds for children with substance use disorder. And about 6 months ago, or maybe it's September, we opened 15 beds. So there's now 15 beds in the state of Maryland for children and adolescents with needs for inpatient substance abuse treatment. It treats both boys and girls, and there's separate areas for transgender individuals. And so that's online, and there is access to services as well as outpatient services for children and adolescents with substance use disorder.
So like 2 days ago, the female wing, I heard, just opened. Mm-hmm. So I really think that we've got a strategy, not just to put them through detox, but now to rehab them. So if we could talk offline, I think that we could do a really great deal. Thanks.
And to the modeling comment, I mean, we are doing some quite a bit of simulation modeling work, and the reason why that's so critical, right, is because we are talking about a complex system, and to your point, right, we do need to understand, like, we're not going to move any of these levers down to zero, right? We need to understand what's the aggregate impact of moving some of these levers, 5 points, 4 points, 3 points, right? And so your point is very well taken, right?
My concern is that when we just put them through the cycle out and just send them back to where they're the place of trauma and where they're addicted, that's just lost money. So we need to figure out something new to shake them up. All right, thank you.
Any other questions for this panel? I don't see any. I want to thank you for coming to the committee. This is the first time you come since we passed the bill. This is the first briefing. It's not the end, right? Because we need to see improvements, right? All the parties to come up with some results that we can see it and we talk to our hospitals, right? And experience it as well, that that it is improving. So consider us a partner, all right? We don't just want to sit here and ask you questions, all right? Anyone can do that. But do you have ways that we can help? Whether it's legislation, whether it's bringing the parties together, whether it's trying to be creative and thinking outside the box, okay? Count us as a friend. All right, we're gonna call the hospitals now, and the same thing that I just said applies to the hospitals as well. No. All right. So why don't we go to the next, and thank you for your work, really appreciate it, and for being at the table. Now I'm gonna call the Maryland Hospital Association, and we're gonna have the president and CEO, former Senator Melanie Griffith, the president and CEO of Frederick Health, and chair of the Maryland Hospital Association, Patrick Carson, vice president of healthcare payment, Maryland Hospital Association, and Tequila. Hi, nice to see you.
Madam Chair, Committee, our board chair, Tom Kleinhansel, shared with you earlier, he has some issues happening at Frederick Health, so he's going to have to leave, so won't be able to join this panel. But we just want to thank him for being here. And
yes, thank you for making time. I know Frederick, it's a long way to come here, so thank you so much for doing that, okay?
I apologize for having to run. I got another mini crisis I'm dealing with.
And look, we appreciate your expertise, your time. Thank you for your commitment. We're very grateful. And you have a blessed evening. Thank you.
Your work as well. Thank you.
Thank you.
And again, Madam Chair, we want to thank you and the committee for your attention on a rainy Friday afternoon to be in Annapolis addressing these. Yes. Oh, you didn't know. You've been in all day. Yeah, it's been raining, just so you all know. But we just want to acknowledge your sacrifice that you're making and your contributions to the health and well-being of the people that you represent and that we collectively serve. You heard a lot from the previous panel. There's a lot of collaboration happening in the state, a lot of great minds working together to address the issues of ED throughput and the time that our patients spend in our emergency departments. I'm going to turn the panel over to Andrew Nicholas, who's our senior vice president, for government affairs and policy. And he's going to walk through our presentation, and Tequila and I are here for questions and any follow-up. Andrew?
Thank you so much. Thank you, Madam Chair, members of the committee. I really appreciate you having us here today and to talk about this important issue. I am Andrew Nicholas on behalf of the Maryland Hospital Association. We do not know who you are. Just in case. But before I begin, I just want to start by saying that we fully realize this is a very serious and critical issue for our state and for our communities and the patients we serve. We know the status quo is not acceptable. Hospitals are on the front lines of dealing with this issue. We are leaning in and working very hard to drive solutions to this problem. I think actually what you'll see in this presentation is a lot of alignment with what you've already heard, and I think that's a good thing. We aren't siloed on this issue or sitting back and pointing fingers. Certainly, we have our differences with our partners on the regulatory side, as you heard, on some of the payment sides. But this is a common problem that we are all working very hard and collaboratively to address. So just with that, and Delegate Chisholm, I did hear your questions. I just wanted to acknowledge before I forgot. I know you did reach out to the Hospital Association. We did connect, I believe, that group with the division of MHA that helps connect third-party vendors to our members. So happy to follow up with you on kind of the status of that. Yep, absolutely. All right, going in here. Oh, excellent. All right, so just a brief overview. I'll be approaching this kind of in three categories. I'll start off by sharing hospital-specific initiatives, what's going on inside hospitals to address this issue. Speak to, you've heard some of the policy issues going on the regulatory side. But just share some of that as well. And then at the end, There are a number of or factors outside of hospitals contributing to this issue across the continuum of care. But that doesn't mean we aren't working on them. We are. There are things being done. It's just not necessarily wholly within hospitals' control to address. And really approaching it from all three of those together, hospital-based, regulatory, non-hospital-based, is really how we're going to move the needle. We're not going to do it just one at a time. So that's the importance of not being siloed and separated on this issue, but really working together. And I'll touch on this at the end, but the statewide ED Wait Times Commission really feels like, to me, in my tenure of working in and around hospitals and on these issues, the best opportunity we've had to do exactly that. Where all three of these issues are represented and actively being worked on through that commission, and I think it presents a really great opportunity to move the needle and improve this issue. So starting off on hospital-based initiatives. So from 2023 through July of 2024, the Maryland Hospital Association convened the Hospital Throughput Collaborative. And really what that was, we brought all of our members together and to share their common experiences, best practices, develop various strategies, examine what people were looking at based on different geographic regions or different patient populations to see what's working, what could be replicated, how could we modify things to appear in different areas of the state. And that was a very robust and I think ultimately successful discussion, because we developed over 50 specific strategies to be implemented in hospitals to help improve this issue. And those strategies were really in three main categories. They were in input, so strategies to help improve, patients coming into the hospital, into the ED, either walking in or coming in from ambulances. Strategies aimed at improving throughput through hospitals. Once you're in the ED, going up to the inpatient bed and moving around within the hospital. And strategies focused on output and discharge. How can we improve and expedite that process? And so when it comes to input strategies, we have hospitals doing things like meeting EMS just simply at the door as they're coming in, and separating patients, doing triage and separating patients who maybe have a less severe illness on one track, and then those who are a little bit more severe may need to be admitted on a different track. So everybody's not in the same queue. It does help expedite people getting the care they need and getting into a hospital bed if they should need it. There's an excellent example of this happening at several different hospitals, but Northwest Hospital in particular in Baltimore County, we had an opportunity to tour their facility is really cutting edge. And we know that there have been multiple hospitals visiting Northwest, seeing what they're doing, learning from them, and how they can replicate that at their hospitals. Throughput initiatives aimed at improving how people are expedited through the hospital. Another area where we're leaning in, there's something called the full capacity protocol that has been implemented at some of our systems, where patients, as soon as a bed is identified for a patient who's in an ED, they're moving them up to that area and stationing them right beside the bed. The patient can see exactly where they're going, and they know they're going into that bed. It may sound kind of strange to have a patient, kind of in a hallway, but they're actually, they're happier. There's a higher satisfaction rate because there's movement. Something's happening. They know they're going into that bed. And the hospital gets to free up that emergency room bed for another patient who may need it. So just trying to expedite throughput throughout the hospital. And then on the output side, examples of things like discharge lounges. So once a patient we know is ready for discharge, but maybe they need follow-up paperwork, they need transportation, instead of keeping them in the bed for that whole time, we have a discharge lounge. The patient can move to that area, again, freeing that room up more quickly so it can be turned over for a new patient to come into. There's many other factors, many other strategies going on in those, but that's a flavor of some of the initiatives that are underway right now in our hospitals throughout the state. Next we're looking at just some of the regulatory initiatives. You've heard about some of these, so I won't dwell on them too long, but I want to highlight just a couple of things. First, the first one, emergency department length of stay. This was a hospital-supported initiative to really put our money where our mouth is, putting over $20 million of hospital funding at risk for improving ED wait times. This is a policy. It is in place now, and hospitals supported it from the very beginning. Thought it made sense to do so, recognizing the significance of this issue. You did hear the HSCRC speak to the ED best practices policies that are in development and rolling out currently. And then we also have the emergency department dramatic improvement effort, which was really informed through the collaborative that I just spoke to. So just a sample of some of the policies that are actively in place to drive change and improve this issue. All right, so now looking at some of the non-hospital areas of focus. Again, these are things that are simply beyond hospitals' ability to do on their own, but there is certainly work being done collaboratively with partners across the continuum and with our regulatory partners to address these issues. I'll talk about these in 3 areas as well. We have issues within kind of some infrastructure and systems within the space. We're focusing on increasing access to preventative and post-acute care services, and then kind of a bucket category at the end of just issues involving workforce, overstays, and capacity. So when we look at our infrastructure and systems within the state, the behavioral health infrastructure is very challenged. That is not unique to Maryland. Honestly, as a country, we're still actually new to the concept of fully recognizing behavioral health as on par or as fully healthcare. And so we're still catching up. And so we do not have sufficient capacity. Certainly at the community-based level, access to lower levels of care for folks to access in the community. And that impacts hospitals. We see more people in the hospital with behavioral health needs because they're not able to access either preventative care or lower level care that may keep them out of the hospital. And then our ability to get folks out of the hospital into a lower care setting. And so kind of having improved care coordination across the state, increasing reimbursement for whether it's residential treatment providers or other community-based providers so that we have greater access to them throughout the state, and then enhancing case management, whether it's for this talks about the SMIs, severely mental illness patients, or really just in general for patients having wraparound services available in the home. That's sort of the gold standard. There are a lot of families who would want to take care of their loved ones in the home. They simply do not have the resources to do so. And that's an initiative. There was federal funding available for this. We hope it will remain, and that we can draw that down to support families keeping loved ones at home. And then the other thing is hospitals have seen a significant increase in payer denials over the recent years, over the last 6 years. Particularly the increase we've seen the most is among our commercial payers over the last 6 years, although there's high rates of denials from other payers as well. And denials, absolutely, they impact patients. They impact their ability to get the care they need. They impact hospital throughput from our ability to maybe discharge someone to a post-acute facility if there's a prior authorization requirement to access that facility. And then even if it's a denial that's maybe after the fact, the patient has come, received the care they need, they've left and gone home, but the claim for that is denied, the physician now needs to spend their time dealing with that and appealing it and not at the bedside dealing with patients. So it is a significant problem. Thanks so much to Madam Chair, brought a very robust group together, maybe the first week of session, representatives from hospitals and payers, MIA, MDH, HSCRC, MHCC, the whole kind of gamut and stakeholders on this issue. There is a lot of interest, I know, from our partners in the space to address this issue, and we are advocating for a state-mandated work group to come together over the interim and find solutions to reduce the number of denials that we're experiencing, and we're excited about that effort.
Happy to know that I've spoken with my sister from another mister in finance, and she chairs the committee, and she actually is my co-sponsor. I'm her co-sponsor, so hopefully that bill will get through as well. And the overstay, as you know, we had a meeting this past week, another group, and I actually have a bill on that as well to address that. So thank you for bringing those problems, but we're committed to working on it.
We thank you, really, so much for your support and leadership. So next, increasing access to preventative and post-acute care. I think you've kind of heard some of this already, so I don't want to belabor the point, but must increase our access to preventative care, primary care, urgent cares across the state. Keeping people well so that they do not develop an illness to the point where they need inpatient care, but also so that there can be, we do have folks coming to our emergency rooms for issues that do not need emergency care, but they simply do not have access to a primary care or urgent care in their community. And so that is one of the areas that the AHEAD model is leaning into. It's something that our members are all very committed to, is expanding that access. And so hopefully through that model, we can drive some of the needed investments in that area. And then secondly, on the post-acute side, again, our partners in the post-acute space are dealing with many of the same issues that we are when it comes to workforce and staffing. That is, again, a national issue. So support continued efforts to increase the healthcare workforce overall. They are also serving a population in Maryland that is getting older and growing. And so they will have capacity concerns. And so expanding access to post-acute services and improving coordination between hospitals and post-acute providers is critically important here as well. So I just want to touch on a couple of other things. The workforce issue continues nationally to be a challenge, but we are doing a lot of things here in Maryland, and hospitals are, again, really stepping in. Since COVID, 11 different hospitals have started certified nursing assistant academies and are rolling out classes regularly of these nursing assistants. This is an excellent entryway into the healthcare field for many people. And so we're very excited about that possibility of growing the workforce through them. Also, we're very fortunate. Our community colleges here have a lot of partnerships with our members, and there are some really excellent programs from nursing, but also in our tech spaces, which are surgical techs, radiology techs. There's a very unique cardiovascular tech program at Howard Community College. And so our hospitals are partnering with our community college to expand those opportunities and try to attract more folks into the workforce. Overstays, as Madam Chair, you mentioned, does patients who are stuck in hospitals beyond medical necessity, they are ready to discharge. We simply do not have anywhere to discharge them to, remain a problem. We see this in pediatric patients who many of them need that lower level of care that there's not enough of in the community. And then we also do see this in patients that are in the guardianship space as well. So there is a bill in, and thanks, Madam Chair, reference regarding the pediatric patients that we're excited about, that we think can move the needle on that issue. There's a work group that came from last year's session that's a 2-year work group on the guardianship issue, bringing together stakeholders, the judiciary, public defenders, patient advocates, hospitals, to try to look at solutions potentially for the guardianship process. I'm hopeful that next session we may see legislation to help improve that process through that work group. So thank you all for your work on that space. And the last point here is really around the capacity issues. We've got to ensure that Maryland hospitals have the ability to care for the patients that need their services. And this is a challenging issue. The model is unique, and as you've heard, the model is not a binary thing. It's not good, bad. There's a lot of great things that have come from the model. There's also some challenges. We thank our partners at the HSCRC for acknowledging this capacity issue and the need to recognize that we have areas in our state that I think are seeing higher volumes than was anticipated under the model and need the flexibility to treat those patients. So we look forward to continuing to work with them so we can address that issue as well. This is just wanted to give one last plug again to the statewide ED Wait Times Commission. You already literally saw this exact same slide, but I think when I see the makeup of the commission, it has representatives from across the continuum of care, and is the work that these subcommittees are doing are all of the issues and factors that we see, needing to be addressed. At our last meeting, which was last Wednesday, look, I know there's some frustration of we're getting into maybe analysis paralysis on this issue and studying it to death. This group is, I think, taking us beyond that, zeroing in on the specific strategies that we can implement in this state to help improve ED wait times. It's not going to be one thing. There's not going to be a silver bullet. If we just start doing this, we'll fix it. It's going to be a combination of 3 or 4 or 5 strategies, but those things combined will move the needle. And at the last meeting, we were really zeroing in on what are those going to be and how can we move from talking about it to working on it and how can we implement it. So I remain optimistic with this commission. We can move the needle and drive some solutions forward. With that, I will submit, and thank you again for listening. Happy to answer any questions.
Thank you so much. It's interesting you said that because I was thinking, why don't we do small pilots as you're doing this, right? Like try it with one hospital and report back, right? And see if it works, right? And then you see, oh, it worked here, it didn't work here, you adjust it, but at least you are trying it. And it's best while you're at the table to try it. And I know the hospitals will be willing to do it as well. I have Delegate Riley, Hutchinson, because I looked to the right first. So you can go ahead, Delegate Riley.
Thank you, Madam Chair.
And I want to thank the members for still being here at 3:39, and we still have one more panel left on another issue. So I want to thank you so much, okay, for being patient. I will make it up to you, I promise. I don't know how, but I will. Delegate Riley, go ahead.
Thank you, Madam Chair. I'm from District 35, so my district is Hartford and Cecil. So I will speak very proudly of our hospital, University of Maryland, Upper Chesapeake Health. Has the commission gone to speak with them and specifically to a doctor, Dr. Lisa Thompson? She actually came up with a new, design or developed a new program to actually move the people from the ER, through the process. And they actually have data. They've been working on this. She created the program, the method, and they have data to prove it. Actually, HGO members, I had them go up there during the interim in October, I believe it was, and they saw for themselves. And it's still working. I just called them today. I said, how's it working? Is it still, so it's still showing great improvement, and it's working, and it was thinking outside the box. I think she did an amazing job. They're not only using it at the Bel Air one, but they're also using it at Aberdeen, and the improvements are on both locations. So again, it may not work in every hospital, but I think it would, behoove the committee to at least go look at it and see, where you can use it or, tweak it to the hospitals.
Absolutely. Thank you for bringing that to our attention. The subcommittee working specifically on hospital operations will begin their work in April, so I'll flag this, make sure that is part of our discussion.
Thank you very much.
And we all went, and I have to tell you, we were so impressed by it, right? We all came out saying this should be the model everywhere. Because in the interim, we do about 2 to 3, visits. And we do some of the hospitals because we want to see. And we were so impressed with it, I have to tell you. We all loved it. Delegate Hutchinson.
Madam Chair. Andrew, that was a great presentation. I'm really encouraged by what I just saw. I represent the Mid-Shore, so I have Shore Health, the worst ED wait times. I'm excited for the new hospital. Even just understanding getting private beds is going to make a big difference in their ED times. But it even goes back to like your title of your presentation. You didn't call it the ED wait time, it was the throughput, because I've always seen this as a throughput issue. The ED wait time is just a result of the fact that we're not getting our patients, through in a timely manner. And I love the presentation about the commission, but I saw an interim report in 2027. And I liked your closing words about that's really going to be the gold star when it's done. But you're trying things and you're doing things, as the chair said, you're piloting things, and that gives me a lot of encouragement that we're out there right now, addressing it. The patient or the example where the patient would be moved up to the floor and sit outside the room and see the room. How long could that patient actually though stay there, or what's the probability of that being in too long of a wait, just sitting there in the hallway?
So I don't know what the target time is, but I know within the protocol that is part of the factors. So they know when to move them up so that it is not an overly long time. The previous patient has moved out, right? So it's not like the other patient is still in there.
Okay,
It's in the
that makes a big
process.
difference, yeah, okay.
It's just in that turnover period while being cleaned and prepared, if there's any time there that they're moving up and can wait there.
Perfect, thank you. Good job.
Thank you. Delegate Whitehouse.
Thank you, Madam Chair, and again, thank you for this presentation. I was very pleased to hear about some of the work that you're doing in increasing your capacity related to your workforce, the CNA academies, and some of the other partnerships you're having with our community college system. I know Baltimore County has an awesome public health pathways program, so I'd like to give them a shout out there at CCBC. But it would be great to have you expound upon, you mentioned techs, you mentioned the CNAs, but we know that it takes a whole lot of folks and in different roles to really provide care. And so where are you all seeing in the field some of the greatest shortages? Is it across the board? Is there more roles than others that you're seeing? Is it primarily in nursing? Is it in the tech space? Is it environmental space? Like, could you expound upon where you're seeing some of the greatest shortages needs, given some of the strategies you're employing to address some of the pipeline issues? And I know that our committee has also tackled that as well, to really strengthen those pipelines. And again, as we're showing here, it's all about trial and error, right? But if you could just expound upon, where you're seeing some of the greatest needs related to staffing shortages.
Absolutely, and what I'd like to do is I'll follow up with you on specific numbers. I don't have them on the tip of my fingers, but it is across the board, unfortunately. We see shortages across the board. However, I do believe nursing is still leading the way in the most critical need. There have been we're likely to have even more nursing shortage coming despite our efforts, because we still see people retiring and not able to kind of quite keep up. So that remains the number one need.
Okay, all right, thank you. Thank you, Madam Chair.
You're welcome. Delegate, who was first, Bandari or the Vice Chair? The Vice Chair? Okay, Vice Chair Collison.
Thank you, Delegate Bandari. Thank you, Madam Chair. And thank you for the presentation. I really appreciate the work that you all are doing. Just wanted to follow up, and first of all, I want to associate myself like 100% with the chair's recommendation about pilots. And I'm wondering, in that vein, I see the policy development, and you said that the hospitals are now working towards the using the global budget notion, value-based care notion in ED length of stays, right? Mm-hmm. And so I'm wondering, have you seen, so is that in practice now? And are folks beginning to gather data around that? And where are the greatest successes in that?
Yeah, so that is actually through the Health Services Cost Review Commission. As the prior panel described, the hospital field has been working very closely with the HSCRC to really look at what hospitals can do. And so certainly optimizing best practices and promising practices is a part of it. And, but I would be remiss if I didn't mention that, one of the things that we see is that hospitals do very well in managing wait times when it's under their control, right? We can tell that, if it's a discharge to home, they've got it. The wait times are usually much lower, and actually lower than national rates. However, when you start to add in things that are beyond the hospital's control, things like the need for an ambulance transport or prior authorization, we heard about guardianship issues, post-acute acceptance, availability of behavioral health services. When you start adding in those components, that's where it becomes more challenging to manage the wait times. And so to Andrew's point, I think it's really the opportunity to work through this commission to bring all of those resources together to work on those solutions. And the HSCRC, so the HSCRC's policy is supporting this work by looking at, what can the hospitals do to optimize best practices within their walls, and then the ED Wait Time Commission is looking broadly across the spectrum to bring in all of those other resources that have a role in this issue as well.
If I might, just a quick follow-up, I promise.
Oh, I know some people, they will really appreciate your questions, so go ahead.
That's right. So the, now I forgot my question. I know what it was. So is the HSCRC considering those factors that are out of your control in the incentive program?
So no, that's not a part of what they consider. And I think, again, the work that they're doing, adding an incentive, I think they recognize that's not going to solve the issue. We certainly know that that won't solve the issue by itself. But the idea of increasing focus in this area and doing all we can to help, I think hospitals are all very much in support of that, which is why we supported the policies and have been working very closely to Ms. Simmons' point, meeting 54 times to look at, different ways to engage and working collaboratively to identify what's working, what's promising, what has potential to solve this issue in terms of best practices. But it's a multifaceted issue, and so it's going to mean a number of solutions coming together for resolution.
Thank you. Thank you, Madam Chair.
My pleasure. Delegate Bhandari.
Thank you, Madam Chair. Our intelligent and wonderful Vice Chair already asked the question from PowerPoint page 8. I don't have a question, but it's very pleasing that you guys are appreciating regulatory agency and you put their stuff on your PowerPoint, and that's the strength of our committee, and the credit goes to our Madam Chair. Thank you, and Madam President, thank you for your leadership, Natasha and Andrew, and we want to hear more, and we want to see the real change. This issue is very serious issues. Thank you.
Thank you. Thank you so much, Delegate. Delegate Johnson.
Thank you, Madam Chair. And thank you for coming to let us know what you're doing, what's going on, and where we may be able to help you. Now, you mentioned one of the biggest shortages was in nursing. So are we seeing a benefit from the Nurses Licensure Compact? And are we seeing a benefit from that? And are some of the shortages due to licensure wait time, testing wait time? Can you kind of...
Sure. I'll say this. Certainly, those have been barriers in years past. Licensure wait time, renewals, wait times. We have seen, since the changes that were made to the Board of Nursing last year, maybe the year before, when it's moved under the Department of Health, significant improvement there, where we really appreciate the work from the Board of Nursing that's gone into that. So I don't have specifically, as far as Compact's impact, I can look into that, but I do want to say we have seen significant improvements in the reviews of licenses, approval of applications, and renewals, and we're still working on issues that impact, that will better facilitate getting nurses in here from other states and other healthcare providers, not just nurses. So there's several bills that are trying to fix some kind of quirks that are out there that and like you spoke to language, there's a language proficiency bill in that would allow Maryland to recognize a more widely used language proficiency standard. Again, just not an extra test before we get health professionals in, and so we are supportive of all of those efforts as well.
All right, thank you. Thank you, Madam Chair.
My pleasure. Delegate Bagnall.
Thank you, Madam Chair, and thank you all for being here today, Madam President. It's always a pleasure to see you in this role. I want to say, first of all, thank you so much for this work and for walking us through the things that you're trying and the outcomes you're seeing. And I just had a question about, we always talk in this committee about who's not at the table, as you know, and how much of it this is through survey information from your member hospitals? How are you going to the hospitals and sort of seeing what's happening, boots on the ground, talking to the staff in those member hospitals? And what does that look like in getting feedback from what's working, what isn't working?
Well, I'll start. All of the above, really. We do survey our members, sometimes more than they might like, but it's important work. It's how we get our information. The collaborative was bringing people physically, maybe over Zoom, but together to speak directly about the strategies that are going on and the experiences that are going on across the state. And then we ourselves at MHA are going physically to hospitals. And seeing firsthand what's going on, which helps us when we're in situations like this. We're working with our regulators to speak firsthand to those models and how they're operating and the impact that they're having. So it really is all of the above.
And Delegate Bagnall, I'll just add, just even earlier this week, I visited a hospital discharge lounge with a hospital CEO and a system CEO. I got to walk through the lounge and see how patients are flowing in and flowing out. So yes, we're absolutely using every tool in the toolbox to impact this area.
Thank you very much.
Thank you.
My pleasure. Okay. I don't see any other questions. You can say they were not paying attention at 3:53 in the afternoon because they were. It's a very smart committee and thoughtful. I'm really blessed to lead it. Thank you for your time and your patience as we went through the questions. I must say that the questions and the conversation was really good and it was needed. It was balanced, and the commitment to work with you is there. We want to work with you and we want to help you. So even after session is done, I know we have several subcommittees that we put together without a bill. I think that, some of our members would like to go to some of those meetings you're having and just, be part of it, of the process if possible. Thank you so much. I appreciate you. Hope you have a blessed afternoon. I must say to my committee, we have one more panel, but I tell you what, I know how I'm going to make it up to you. There was a briefing scheduled for next Friday. No briefings next Friday. Okay? I just texted Michelle, and I don't know that she's going to like it. I know she must be hearing this. And I said, I will not schedule briefings next Friday. And it was on the calendar so that you can have at least an afternoon off, okay? Why don't we go on to the community violence prevention? We have the executive director for UMB, the University of Maryland Baltimore Center for Violence Prevention. We have the vice president of government relations and community development for LifeBridge Health. And we have the executive director for Center for Hope and vice president of violence intervention and prevention at LifeBridge Health. And I want to say thank you for waiting patiently at 3:55 in the afternoon to be called. Hopefully you know everything you need to know about hospitals and HSCRC, right? So welcome to our committee. As you see, we have, I would say, we have 19 out of the 23, and that's pretty good. We have someone who had to go to a funeral, someone who had to travel, so they're excused, but we have a good number of people left. So we're all yours.
Good afternoon. All right. Good afternoon, Madam Chair, Madam Vice Chair, and the members of the Health and Government Operations Committee. I don't have slides, so they're trying to get the slides for the other.
Okay, that's okay.
So
yeah,
don't worry.
That's all right.
So my name is Dr. Nadine Finnegan-Carr. I am a prevention research scientist.
Hold on a minute.
Oh. Start again? Sure. Whenever you're ready, Erin.
Yeah, just come over. It's okay.
Got it?
Yes.
Perfect. All right. Good afternoon, Madam Chair, Madam Vice Chair, and members of the Health and Government Operations Committee. My name is Dr. Nadine Finnegan-Carr. I am a prevention research scientist focused on the application of behavioral and social science perspectives to research on contemporary health problems. So even though it was long, it was interesting to sit through the previous panels. I specifically focus on issues that relate to primarily people of color and disproportionately impact them. I am an internationally and nationally recognized expert on community violence, especially youth aggression and violence, human trafficking, intimate partner violence, domestic violence, and sexual exploitation. On May 1st of 2023, I became the inaugural executive director of the University of Maryland, Baltimore Center for Violence Prevention. That was our established date of May 1st, 2023. Our mission is to build resilient and equitable communities for all through the prevention and intervention of all forms of violence and trauma. Our work is trauma-informed and rooted in racial equity and social justice. I have brought copies of our first report for you all to review, and I believe Erin has already passed them out. A wise woman once said, "A vision without action is a daydream. Action without vision is a nightmare." And since I stepped into this role, I have worked to make the vision for this work clearer and take action towards implementing it. The violence that's plaguing Baltimore City, the state of Maryland, and our country writ large is already a nightmare. So our aim is to provide hope. I often define violence as the child of trauma and poverty. The World Health Organization defines violence as intentional use of physical force or power, threatened or actual, against oneself, another person, a group, or community that results or has a high likelihood of resulting in injury, death, or psychological harm. No matter how we define it, violence in all of its forms is a catastrophic problem that needs to be addressed. Too many of our young people statewide are lost to violence and neglect. Those left behind experience trauma due to this community violence. Without intervention, these are youth and young adults who will never realize their full potential. As we have envisioned it, the overall mission of the UMB Center for Violence Prevention is to interrupt and intervene on all incidents of and all forms of violence. Non-fatal violence, especially. We hear a lot about gun violence, but non-fatal violence is a major risk factor for subsequent assault injury and often precedes fatal violence, like gun violence. Someone who is intentionally injured is significantly more likely to engage in violent behaviors than someone who is unintentionally injured. Gun violence and homicide are definitely serious forms and outcomes, but we need to intervene on the various forms of non-fatal violence before they escalate to the level where someone's life is threatened. Because at that point, it's too late. With an interdisciplinary approach, the center collaborates and partners across communities, academic institutions, nonprofit organizations, governmental bodies, corporations, and philanthropic organizations to bridge together and advocate for informed policies and interventions towards violence prevention and creating social justice for all. We believe all individuals must thrive in a safe and equitable environment, and this is achieved by preventing violence. Our goals for the next 3 to 5 years will be achieved through collaborations and community-based partnerships to conduct research, develop creative and impactful education, and advocate for policies that strengthen our communities by establishing a community of practice. These goals align with the University of Maryland, Baltimore's strategic planning goals. Bridging activities across UMB and in the community in an interdisciplinary, collaborative fashion, we conduct community-based participatory research by expanding the evidence base for violence prevention strategies. Our second goal is to work with the wider Baltimore and Maryland community, along with faculty, staff, and students, to establish this community of practice that works collaboratively to reduce violence. And lastly, we aim to train and educate professionals and future leaders on violence prevention and how to address this issue from a public health perspective in an interdisciplinary fashion. research, community, training, and education. Those are our goals. My work in building the Center for Violence Prevention began more than a decade before it was established by UMB through the Prevention of Adolescent Risks Initiative, or PARI. Our PARI team has built a cadre of research initiatives related to community violence and trauma support and minor human trafficking. Our first statewide initiatives were to build the infrastructure for Maryland's Department of Human Services Social Services Administration to address human trafficking of children and youth. We worked tirelessly with the agency, nonprofits, and survivors to change policies, revamp training programs, and establish statewide multidisciplinary teams that work with law enforcement to support victims in their journey towards becoming survivors and thrivers. We have been continuously funded by the federal government since 2014 to do this work, funding that is currently being threatened. Most notably, we developed the statewide mandatory training for social workers on human trafficking required under federal law PL 113183, the Preventing Sex Trafficking and Strengthening Families Act. We were responsible for rolling it out and training all workers in 2017. This training is now required of all new social workers in the state of Maryland during their 2-year onboarding period. We currently serve as the training and technical assistance provider for Maryland's Regional Navigator Program. This program was developed after then Governor Hogan signed into law the Child Sex Trafficking and Screening Act of 2019, which required law enforcement agents and local departments of social services to notify a regional navigator in their jurisdiction to obtain needed services for child victims of sex trafficking. There are regional navigators in every jurisdiction comprised of human services professionals from child advocacy centers, sexual assault or domestic violence programs, and specialized victim services providers. In addition, we have utilized our research on minor human trafficking in Maryland to provide one-pagers and web briefs used by community partners and your fellow policymakers when discussing potential legislation. As today marks the last day of Human Trafficking Awareness Month, I am proud of the work that our center's PARI team has done to address human trafficking in our state. Most recently, in the fall of 2024, the center received external funding from the University of Maryland College Park's Progress Initiative for research to examine the framing of media stories about gun violence across our state. This research is being conducted in collaboration with our community partners, Leaders of a Beautiful Struggle, and input from individual community members. The Center for Violence Prevention, we may be in our nascent stage, but we have hit the ground running with our research and training programs in an effort to reduce the burden of violence in Maryland and across the U.S. through our research, evaluation, policymaking, training, and partnerships with community agencies. We are here to serve as a resource for the Maryland legislature in making Maryland safer for all of its residents. Thank you for the opportunity to address you this afternoon.
Thank you for your work. Really appreciate it. Very impressive. And thank you for making the decision to live here and work here in Maryland. I think
30-something years, I don't have a choice.
Our constituents are very blessed. Thank you so much.
Thank you.
Next.
Good afternoon, Madam Chair, Vice Chair, and committee members. Thank you for staying with us, and thank you really for the opportunity to present here before you. Jennifer Witten here today representing LifeBridge Health, Vice President of Government Affairs. It's always a privilege to be in this committee.
Jennifer is a friend, if I may interrupt for a second, being rude, of HGO. Like, she has worn, many of you know her. She's worked with the Hospital Association and other organizations. So it's great to see you back in that role.
Thank you, Madam Chair, and I really value this committee. I learned a lot over the last few decades of the important work that you do, so thank you. Really, I'm going to turn it to my colleague Adam Rosenberg here, Executive Director of Center for Hope. But I just wanted to share a little bit of context. You heard a lot about today the critical infrastructure that health and hospitals are doing here in the state. A big part of what we do also is really investing in kind of the community needs that we identify, working with a number of community partners. So as this committee may know, every 3 years, hospitals are required to go through a community health needs assessment process. And in that process, we work with local state health departments, we work with other stakeholders, community members to identify what are the really critical issues that are driving either limited access to healthcare or poor healthcare outcomes. And what I would say, unfortunately, is what we're seeing, at least in our system, and I should say, just quickly, LifeBridge has hospitals both in Baltimore City at Sinai Hospital, which is near the Pimlico Racetrack. We have Grace Medical Center, which is in Baltimore, which is a converted freestanding medical facility. We have a hospital in Randallstown in the Delegate White Hollins District Northwest, and Carroll Hospital. But what we're seeing in those community health needs assessment is this issue of safety and violence in the community as being one of the top tier pressing issues. More so than chronic disease, we see food insecurity, safety and violence prevention and need for intervention. So as a health system, I'm proud to sit before you today to share, and my colleague will share, the multi-pronged strategies that we take here at LifeBridge. We are very unique. We have one of the only models in the nation where we actually have a child advocacy center and a multitude of entities that are doing many of the strategies that our colleague here presented in really addressing violence early, providing that intervention, being a trauma facility when needed, but also looking at those wraparound services for those victims that unfortunately do face violence. And so with that, thank you again for your time. I'm going to turn it to my colleague, Adam Rosenberg, who's going to talk a little bit about some of those programs.
Thank you so much. Thank you. Thank you, members of the committee. I recognize that I am all that stands between you and the weekend at this point, so I'll make this entertaining and brief. On the screen here, you can see our Jill Fox Center for Hope, which we opened up in May 2022, and is the physical manifestation of the commitment that LifeBridge Health has towards responding to violence all throughout our health system. Center for Hope was created in 2019 through the combination of several organizations that have over 40 years of history in violence intervention. The former Baltimore Child Abuse Center, which is the city's child advocacy center, the first in the state of Maryland, the third oldest in the nation. Our Dove program at Northwest Hospital, one of the oldest hospital violence intervention, domestic violence programs, and our hospital violence intervention teams at Sinai Hospital. And at the time, we had 1 Safe Street site. Now we operate 6 of them there. We're also the city's human trafficking navigator, as my colleague Nadine referenced earlier there. So we're responsible for coordinating not just child abuse and child advocacy investigations in the city, but also running point when it comes to human trafficking. The Center for Hope was built on this mission to be able to be that one-stop shop for any violence that LifeBridge Health and its partners encounter there. And so we have many different partners and many different calls to action, but really the goal is recognizing that all of these streams of violence are public health issues. And it's our goal, frankly, in tying on the last hearing you had, we want to keep people out of the emergency room. We want to keep people out of having to go see a health practitioner because they've been injured, because they have a mental injury due to years of violence, due to being shot, due to being sexually abused or raped. We want to be able to keep the community healthy. And that's been our overarching goal with launching this Center for Hope here. As Jen said, our number one social concern from our neighborhoods was violence, whether it was gun violence or community violence or violence from family members. They're concerned about keeping themselves safe, and that's what our role is in this here. Center for Hope each year helps about 5,000 people. We almost have 1 encounter every hour of the day throughout our various programs and sites there. We're helping children escape child abuse there. We're working with women who are looking to avoid domestic violence. We're providing them with shelter. We're providing them with a great deal of legal advocacy in courtrooms there, helping them get the emergency protective orders necessary to keep themselves safe. We meet people bedside. And so we're doing the things that many are studying. We've been doing this for years, and putting it all together and then connecting these various threads, because we also recognize that all of this violence is in fact related there, that no one is a victim of only child abuse or no one's a victim of only gun violence. When we look at our data, unfortunately, our children who've been survivors of child abuse in Baltimore City are also living in the very same communities that have had high rates of gun violence and high rates of other forms of violence there. And so to help people heal from violence, we need to be able to attack multiple symptoms at the same time and help them get out of those situations there. And that's really through a lot of our high-risk mediations in neighborhoods there, as well as the people we're training, over 14,000 people online and in person there. We spun up the state's mandated reporter website almost 10 years ago to make sure that reporters know their responsibility and how to make a report of child abuse there. So we're working in all fields of violence and advocacy throughout the community. Really brief, maybe you know this, maybe you don't, but I love showing this slide because it shows that LifeBridge Health and the work that we do is part of a vast community health system. I think it's one of the things that each of our health systems has its own unique niche, and one of ours is our role as a community health partner. I think the phrase "care bravely" that we often use at LifeBridge Health really is our mission and mandate there, and we're caring bravely for the health of our community through all of these various entities, whether it's the 5 hospitals that Jen spoke of, it's our urgent care centers there, it's our community service through the Family Tree and through Center for Hope. We're here to help keep communities safe. We really look at Center for Hope and our programs across 11 different sites throughout our region, from Baltimore City, Baltimore County, and now Carroll County, in 4 different buckets. One is crisis intervention. And so we as a health system are involved in leading our child advocacy center efforts there, with mental health systems, with forensic interviews, with medical examinations there. We're the anti-trafficking point person, we're the domestic violence program. We even are working to prevent and respond to elder abuse as well there. 24 hours a day, 7 days a week, our staff's available and on call. We have 3 medical examination rooms spearheaded by a board-certified child abuse pediatrician, one of the few in the state who can examine children and recognize signs of abuse, physical or sexual, and help that child get the resources necessary to help them heal. We're also seeing kids who enter foster care, making sure that they meet that federal mandate in Baltimore City and Baltimore County to get a well exam before when they get removed from their home there. One of the unique things we've been doing, and I love that Nadine mentioned this too, is the need to reach out to, bless you, the need to reach out to youth who've been exposed to homicide. It is a horrifically underserved group there, and if we don't reach these folks who've been the siblings of people who've been shot and killed, the friends of who've witnessed murders there, they become our next murder victims, they become our next trigger pullers. And so we're doing youth programming to help those people build resilience there. We've done remarkable work preventing gun deaths, not just through our hospital violence interruption teams at bedside, but in the community. And that's the essence of the Safe Streets model, through mediations there. We recognize that when we mediate a conflict, those people aren't ending up in our hospital. And shortly I'll show you a slide that demonstrates the statistics and impact of how we've driven down gun violence in our communities and within our hospital as well there. And we're constantly building better responses. We're teaching this next generation of advocates to be able to do this work as well. We partner with many people. You've got the slide deck. I want to, respect your time here. But, we don't do this alone. I think that's really part of this. We're part of many multidisciplinary teams there, working with our local law enforcement, working with federal officials, working with Child Protective Services there, community partners, youth organizations, all who have a hand in the community's efforts to prevent violence wherever it manifests itself there. A touch on our advocacy efforts. We use the term forensic interviewing. We're the folks who are interviewing kids who've been victims of child abuse and trafficking in Baltimore City. It's our team who are trained in asking a non-leading, safe, trauma-informed manner what happened to a victim of violence, whether it's a child or whether it's a vulnerable elderly person there. And by doing that, we can get their story in their own words captured in video HGO and available for use in criminal proceedings and civil proceedings, Office of Administrative Hearing proceedings there too, to then make sure that people are placed in safe settings there. And by partnering with LifeBridge Health, by having this been really one of the missions of our organization there, we realize that there are medical services available for all of these clients, and so we can get them that help that they need there. A couple statistics I'd love to share is that when we've surveyed our children and our caregivers, 95% of them feel safer. I mean, let that sink in there, that when they've come to us and they've been with us there, they feel more self-sufficient, they feel safer after being with us. It doesn't necessarily mean their case is going to be prosecuted. That's the discretion of our local state's attorneys, or if someone's able to be arrested, that's the police department's role. But we want to give them the resources they need to help them heal from that violence again, through medical examinations, through mental health therapy there, and through giving them access to the resources that are out there. We run behavioral health clinics on site. We've got our own licensed social workers who are under a great deal of supervision and care continuity with the mental health services we provide there. We provided almost 3,000 therapy sessions last year for about 150 clients, all of them finding it healthy and in a safe location. The same space where they went, where someone heard their story about abuse, is the same place they're going back to be able to get the help that they need there. And all that's provided, frankly, through many of our grants that Nadine was speaking of as well, that are frankly under risk from our federal government. And even in the budget, there's the Victims of Crime Act is slated for a cut there. These are the monies that make these things happen, that few other people fund, frankly. And those are the programs that the Victims of Crime Act do fund. Mental health services for free, medical services for free. Our domestic violence program, we're a comprehensive program in Northwest Baltimore there, providing safety planning and case management there. And again, over 2,000 clients there who get shelter care, who get therapy, and they feel safer too. And this is the responsibility of health systems, and we're starting to share with health systems throughout the country how they can do this work as well. The data and the stat I really want to get to is some of this work that actually happens in the hospital here and how we prevent people from getting shot. We've got bedside teams at Carroll Hospital, at Sinai Hospital, and at Grace Medical Center, and they meet people bedside after they've been shot. They wake up in what we call the golden hour, when they have that moment of recognition that they can do something to change their trajectory, and we're helping them either not go out and retaliate against the gun violence, or find them the resources to move to another community, or to do other behavior to prevent them from falling back into that same trap there. And it's successful. It's a safe and it's a confidential setting. They trust our community violence or hospital violence interrupters who look like them, who understand their plight and their struggles there, and connect them to the resources available if they need assistance with rent, if they need help finding a job, if they need help with an expungement of a prior record to get that job. We can help them do that there. We run 6 Safe Street sites. This isn't the Judiciary Committee. I don't need to go too much into detail as to the dynamics of Safe Streets there. But suffice to say that these are programs in 6 neighborhoods throughout Baltimore City that have been assigned to us by the City of Baltimore there, where have among the highest rates of violence there. And we've got people on the ground now in the rain, walking around with orange jackets on, meeting people and mediating violence. Learning about the conflict that exists between people, and the community trusts them to turn to them and to say, I think that's going to escalate into gun violence there. Can you help mediate the conflict? I say it much less artfully than it actually happens there, but it's remarkable how it works. And as a result, we were able to do 876 mediations last year, 150 community events. We met with thousands of community members there, and these community members feel safer thanks to the Safe Streets program that we're running through this health system there. They're more sufficient, and in our sites that we have 6 sites. There were only 6 total homicides from these sites over the course of a year. 4 of those sites had no homicides for a period of over 365 days. That's a record for Baltimore there. We haven't had neighborhoods with no homicides that were our high violence neighborhoods in a long time there. And we are by no means the only one, but we are part of this turnaround for reducing gun violence in Baltimore City as well there. And that resulted in a 52% reduction in gunshot wound admissions since fiscal 2021 at Sinai Hospital. It's incredible that there were almost half the people who presented back in 2021, they're not there now. And we've checked the data through MIMS. They didn't go anywhere else. They weren't shot. And the reason they weren't shot, there are many factors there. I mean, gun violence is down in America, but there's an all hands-on effort right now in Baltimore City. Many different partners doing that. But a big part of it, frankly, is our safe street sites that surround Sinai Hospital are meeting with people, are mediating violence, that we're working with children who've been victims of child abuse, who if they have no one else to turn to, that's when they turn to violence, that's when they turn to gang activity there. We're giving them that wraparound care, and we're doing that to make sure that we are not getting shot. And what's that doing is, hopefully it's reducing ER wait times, but it's keeping our community healthy. And that's really part of our mission here at LifeBridge Health, is to make it a point to do the different efforts and to try the innovative things and to leverage our strength as a health system to be able to keep our community safe, to provide those resources, no matter who's been a victim of violence, when they come to LifeBridge Health, and set them on a path for healing there. And with that, I'm eager to hear any questions or wish you well for the weekend.
I'm going to open it up for questions. First, I'm going to start with Delegate Taveras.
Okay. Thank you, Madam Chair.
My pleasure.
So this sounds amazing. I'll try to wrap it up in 3 quick questions, because I know I'm me between the weekend. Okay. What's the long-term care for kids? Like, you're helping them when something happens, but then what, right? To make them feel safe long-term, not just, and then do you encounter teen parents in this? Maybe what's the percentage in that? And then love the de-escalation. I think I just saw you guys on saw something about it on TV, and I don't watch TV, so impressionable. Kudos to you.
Hopefully it was something good you watched. What's the long-term plan? Look, the beautiful part about having funding from the governor's office, the federal government, around Victims of Crime Act is that we're able to provide free therapy for as long as the family needs it. We know we can't keep a family with us forever because we've got a wait list of people wanting to come in and get that next slot there. But we want to be able to create a strategy to package a family up and either get them out of therapy or get them to the next therapist who can help them on there. So journeys vary greatly, Delegate. Some of them are 6 weeks, some of them are 6 months, some of them are 2 years. But at our space, we've got play therapy, we've got a variety of trauma-informed therapies, EMDR, CBIT, to be able to do that there. And part of that also, and I think by being an advocacy center, we're also able to make sure that we can eliminate the barriers that families have in getting to therapy. So we probably spend close to $40,000 to $50,000 a year on Lyft and Uber to make sure we can provide transportation for families, because we're not a transportation city. This isn't that committee, but that it's difficult to get people to our center sometimes, and if we don't provide the free ride, they're not coming. We provide the child care so that the child and the caregiver can get help, and if the siblings need to be watched, then we have someone who can watch those siblings. So I think that's part of our care plan in a little bit of a nutshell, how we help with that. With teen parents and parenting in general, I'm really lucky and fortunate to also have, as one of my programs I supervise, the Family Tree, Maryland's Prevent Child Abuse America chapter. And they are a remarkable program that provides those resources for families of all ages, including teen parents, to help them be better parents. Everybody wants to be a good parent, and there's no manual that comes with it. And the Family Tree is available with their parent helpline 24 hours a day, with parenting classes that are are available, and even some home visiting programs there that I believe my colleague Stacey Brown was testifying here before you all a couple days ago about the importance of home visiting and how we can send someone home with a nurse to help them on that journey of parenting. And I forget what your third question is.
No, I was just
Okay,
giving you
yeah.
kudos on
But that's a little bit what we're
the
doing, yeah, thanks.
de-escalation.
Yeah.
The zero, because
Oh, and zero reduction is, thank you. I mean, it's a lot of different pieces that come into it there. And I think that it's because we have a steady presence in our communities, making sure we provide that wraparound care and really providing resources for youth, as there aren't really many that are out there. We have a youth radio station in 2 of our Safe Street sites where we're letting youth do podcasting and telling their story and giving them a voice and an outlet. A group for teen girls who we've been managing now for close to 12 years, helping them, try and, learn how to mediate conflict and also hopefully not get pregnant.
well, we'll love to talk to you more offline.
Anytime, and I invite everybody to come see the center too.
Thank you.
We're in Delegate Rosenberg's district there, and so overlooking Pimlico Track. He'd be happy to host everybody at our space.
Thank you, Madam Chair, and I want to thank you, Dr. Finnegan-Carr and Mr. Rosenberg, and Jen, so good to see you. But I want to thank you for the work you're doing, and it's wonderful that you are situated where you are. I'm wondering what it would take to replicate this model in other areas of the state, because some of your partners have a statewide presence. So, is there, any inclination? I know funding, so I know that's a big barrier, but I guess I'm asking, has there been discussion about that?
I mean, we've always had it as our, it's part of, we've always been eager to host, and we've hosted delegations from across the world, from across the country, who come to see what we built and how we do it. I think it's a great conversation to have, frankly, of how can we help replicate this? How can we help run it for different areas of the state? I think one of the things sometimes we do in Maryland is we want to run, one thing in every county or every hospital, and I think that there is a regionalization we can do to some degree with some programs like this and have that capacity of scale. But there are things that can be done there, that there are child advocacy centers in our counties, there are human trafficking navigation programs in our counties, and there are hospitals that service these counties as well. And I think it is the obligation of a health system to lean in and to find ways to be able to, not just, not just a patch and release, but to be able to find the strategies to prevent it. So I think we can do it. I think obviously some of it is unquestionably funding there. That's a big part of this. None of this is free, but it's able to, leverage, I think, some of those resources there and to work smarter and not harder in that regard out there.
And just jumping in, I think specifically for human trafficking, having rolled out the Regional Navigator Program, of which you all are one, and having done the training for all of the regional navigators, it is definitely something that can be replicated in like form with the other pieces that Adam and others are doing, especially in jurisdictions that have child advocacy centers, because that's a central way of providing that training and then reaching out from there.
Great. Thank you very much.
Thank you. I don't see any other questions. I know that this body years ago passed a bill, Delegate Smith, to make sure that we could reimburse for that work. So we're very proud of that. Thank you for the work you do. It's important to deal with someone that has been the victim of a crime, right? And especially young kids, and to give them those tools they need so that they don't become a victim or become, the assailant. So thank you very much for what you do. It obviously works. It shows. I'm really grateful that you came and updated the committee on the work you're doing, because it is part of our healthcare, right? It is healthcare as well, and I think that it's really important. I value it, and I thank you for your time and for your patience while we got through all those other presentations. And if we can ever be of any service, please let us know as well, okay?
Thank you.
Have a blessed day.
Thank you for the opportunity.
Thanks for making a difference.
Thank you.
Have a blessed evening. For the committee, this actually concludes our bill briefings for Friday. It is January 31st. It is 4:30 in the afternoon. I hope you get to get some R&R this weekend because I know you worked hard. And as promised, next Friday, there will be no briefings, okay? Have a great day. Thank you. You can bring us down.